Morning. Ooh, good morning, everybody. Hey, no, you can keep the music. It's okay. Eric, all right. Kill the music. Whatever you want. I think this morning is going to be a bit smaller than yesterday and the day before. What I may encourage everyone to do is if we could move up to the front rows, like the first 3 tables, I think it'll be more, I don't know, it'll be cozier. Huh? Uh-oh, there's a word.
Gezellig.
Gezellig. Intimate. It's cozy, intimate, and stuff. All in one. Now, Eric, these lights, now that the conference is basically finishing, do we need them? Those lights that are shining in everyone's eyes, is that... Okay, because it's hard to see everybody. Okay, that's fine. What time is it now? 8:40. I mean, we'll give 5 more minutes for those that were hit the bar last night a little too much.
Best.
Well, welcome everybody to day 3 of the PPA conference. Just before we begin, we have a bunch of bags left over. And so I figured I'd auction them starting at $100. Anyway, no. But if you like these bags, these are excellent. I'm have to force you to give them away. You go to the grocery store, instead of using plastic bags, you use this bag over and over again. It's eco-friendly. Then people will ask you, hey, what's the PPA? And you'll tell them. So anyway, help yourself to bags there in the back. And Jeff, maybe you'll come up. Thank you.
Good morning. Dr. Subramani was trained in neurology and electromyography, neuromuscular diseases at the Cleveland Clinic in Cleveland, Ohio. After being on the faculty at the University of Mississippi Medical Center for almost 30 years, he has since directed the adult muscular dystrophy clinics and the ataxia clinic at the University of Florida since 2009. Over the past 25 years, he has had an investigative interest in genetically determined neuromuscular disorders and hereditary ataxias. He is focused on translational research to bring innovative therapies to these disorders. Dr. Subramani is considered one of the world's leading experts in these fields. Currently, he focuses on genetic neuromuscular diseases and ataxias and offers treatment that includes electromyography, muscle biopsy when appropriate genetic testing, and referral to ancillary services such as physical, occupational, and speech therapy and evaluation for mobility aids. Please welcome Dr. Subramani. Hi there. Would you like this in the stand or would you like to hold it?
I'll hold it.
Okay.
Thank you very much for that very kind introduction. And let's see. So I would like to take you to a little bit of history of my own with regard to the periodic paralysis, because as was pointed out, my current translational research involves a variety of genetic neuromuscular disorders, particularly myotonic dystrophy and Friedreich's ataxia, which have a different mutational mechanism than what you see in periodic paralysis. But my interest was triggered years ago when I was a junior faculty, and I saw families with hyperkalemic periodic paralysis, paramyotonia. I tried to understand the phenotype of these disorders, did some publications. Some of the tests which I described in the 1980s are still used commonly to evaluate patients with these periodic paralysis and paramyotonia congenita, such as the exercise test, the cooling test, etc. So I was intrigued by these disorders. Unfortunately, I didn't have a large collection of patients afterwards, so did not develop those interests. Now, the history of this is very interesting as well in a larger sense. We had a little bit of the history before. In fact, the first of these disorders to be clinically described was paramyotonia congenita in 1886 by a German physician by the name of von Eulenberg. And then I cannot quite clearly say who described hypokalemic periodic paralysis. There was a name mentioned yesterday, I missed that, but in Europe, this is often called Westphal's disease, and I don't know who Westphal is. And then it was 1956 when Gamstorp, a pediatrician in, I believe, one of the Scandinavian countries, described a family with hyperkalemic periodic paralysis. And it turns out that serum potassium, the ability to measure it developed in the 1930s. And I got intrigued by this last story here, elementary, my dear Dr. Allen, is because I heard of this story, a disorder in China that they call Paping. And the British physicians in the 1940s in Shanghai, I believe, were seeing patients, mainly men, almost all men, who would turn up in the emergency room paralyzed and had low serum potassium. They were able to measure the potassium, and then they were able to give them potassium, make them better. Dr. Allen was a Canadian missionary physician in China at the time. He and one of his Chinese colleagues eventually came to the conclusion that these men, over the weekends, they all turned up on Saturdays. So there was a pattern to this. The men would eat out, the women did not. They would go to the theater and then eat out. And the restaurants, the salt was contaminated with barium, which was not the case at home. So chronic barium toxicity leads to chronic hypokalemia, and these patients would come in with repeated episodes of periodic paralysis. It was not genetic in nature. The local name for this disease was Paping, and Lauren Bowen was one of my medical students who researched this, actually managed to interview the niece of Dr. Allen and wrote a wonderful historical paper about this particular disease. And fortunately, one other piece of history in my own, and was that I actually missed this patient. My name is somewhere in the middle when we found the ATS gene mutation. This was a young lady with hypokalemic periodic paralysis, and I missed the boat till several months later when I learned that she had suffered with a cardiac arrhythmia, and I was scratching my head, what is happening here? And I was able to share the DNA in this family with Dr. Lou Patachek at that time, and be part of this story of figuring out the potassium channel mutation in Anderson-Tavil syndrome. So what I want to do is kind of give my take on this group of disorders. As you know, a paper that was, I think Dr. Levitt was part of this publication, diagnostic delay of more than 20 years after onset of symptoms. That's often the case with the periodic paralysis. What I found when I was dealing with many families, or some of the families, I wouldn't say a large number, they actually often knew that there was a familial disorder, especially with a genetic disease. And some of the families, and the attitudes may have changed now, were not very ready to admit this issue because the children were in athletics in high school, and they were not sure that they wanted to publicize this condition in the community. So that was one of the interesting things that I experienced. Many patients do get missed. They get told that it's all in their head. But then on the other hand, you have a real problem in the medical field of patients with weakness and fatigue who get, not sure that what it is. Is it periodic paralysis or something else? Now, physicians and patients often have different meanings to the word weakness and fatigue, and these often get interchanged. A lot of patients equate the two. Physicians want the weakness to be paralysis, actual loss of strength in a muscle. Fatigue, I can be fatigued, and yet if a neurologist examines me, I may have a normal muscle strength. So that kind of makes it a little bit harder when you end up in an emergency room or an urgent care clinic. Unable to be seen by experienced physician during an attack. And I often ask patients to bring videos of them when they have an attack. So that gives me a little better feel for what's happening with these episodes, because we don't often get to see them. Commonality of these symptoms in an urgent care setting, because many of our patients do end up in the ER during an episode, but there are lots of patients who turn up in the ER with fatigue. I can't do anything, I'm tired, I just, and that makes it very difficult for physicians who are unfamiliar with the disorder to sort this out, because this is indeed a rare condition overall. Now, we've discussed some of the pathophysiology of it at great length, so I don't need to belabor the point. But periodic paralysis is a disorder of the muscle, not of the brain, not of the spinal cord, not of the nerves, not of the neuromuscular junction, but in the muscle itself. You can see a large muscle arranged in fascicles. Within each fascicle, there are these long cells, very long cells. They go from here to here, for example, in the leg. Multinucleated cells, which are covered by the cell membrane. And here is a blow-up of a muscle cell. It's got the contractile proteins within it, and you have an electrical activity that is transmitted to the muscle cell from the nerve through the neuromuscular junction, and then it's translated by a mechanism that we call electromechanical coupling. So you have to turn that electrical impulse into a mechanical message, and these proteins actually slide together in a bridge formation that causes the muscle to contract. The problem in periodic paralysis resides in the sarcolemma, or the membrane of the muscle cell. You've seen these cartoons before, and again, I don't want to spend too much time. There are mutations in the sodium channel, calcium channel, potassium channel, and of course, chloride channel causes myotonia congenita, not periodic paralysis. These are these cylinders, cylindrical proteins stuck on these muscle cell membrane that allow rapid transit of these ions to create that electrical activity and electromechanical coupling. Again, without belaboring this point, you have these muscle cells are negatively charged inside. During an action potential, this negativity rapidly rises to a threshold level. Once it reaches a threshold, you have a all or none. Once it gets here, it is going to act, and this will be conducted along the cell membrane. Notice the timing. This is about 1 to 3 milliseconds, as you can see. And we do know that in almost all of these mutations, you have a problem when the muscle cell gets paralyzed. It does so because it is partially depolarized. I think of it this way. In a normal cell, you need this momentum from minus 90 to minus 65 or 70. This momentum is needed to kick off this action potential. If it is here, the rise from here to here does not create that momentum, and the muscle cell is electrically inexcitable. In all forms of periodic paralysis, the muscle cell membrane is electrically inexcitable. The cartoon again, so what you've done here is cut open the cylinder and spread it out in a flat surface. And again, a cartoon you've seen before. These are the hypokalemic periodic paralysis mutations. About 60% of them are calcium channel, 20% sodium channel. We talked about the arginine residues that seem to be the common factor in these hypokalemic periodic paralysis mutations. The hyperkalemic periodic paralysis mutations involve the sodium channel, and I was quite pleased to hear from Dr. Catterall yesterday that the pore abnormality here is a leaky normal pore. Here it is not through the normal pore, so that kind of makes sense to me that I had not heard of before. And of course the potassium channel mutation and the Anderson-Tavil syndrome. Now, I think the calcium channel mutations which underlie hypokalemic periodic paralysis is a reasonably clean phenotype. Does not have a whole lot of complications. There is variability. For example, we know that it is reduced penetrance in females, for example. There's variability. However, in the sodium channel mutations, the clinical picture is quite complex. So if you have a DNA result that says you have a sodium channel mutation, that does not automatically translate to hyperkalemic periodic paralysis. You can have that syndrome. You can have the disorder that we call paramyotonia congenita. The reason it's called paramyotonia congenita is in other myotonic disorders, when you activate the muscle, the myotonia goes away. Whereas in paramyotonia congenita, the myotonia intensifies with activity for a short period of time. We call it paradoxical myotonia, which is often followed by actual weakness of the muscle. But one of the key features of paramyotonia congenita mutations is that I believe they're cold sensitive. So unlike other people with other mutations, these patients, if they expose the muscle and lower the temperature of the muscle becomes electrically silent. For example, one of the complaints that my family members gave me was that they could not eat ice cream. If they ate ice cream, they could not speak or eat for several hours because the throat muscles were paralyzed because of the lower temperature. Even after you warm up the muscle, it takes several hours for it to come back. There are mutations in sodium channel which gives you a myotonia only, nothing else. This has been called sodium channel myotonia, but this also may go under the name of potassium aggravated myotonia. So just myotonia without paralysis, without cold sensitiveness. And then of course you can see hypokalemic periodic paralysis from these mutations as well. And I'm concerned that many patients and families with different mutations, there may be overlap of these clinical picture, if you will. What I mean by that is, even though in the literature certain mutations are associated, for example, potassium aggravated myotonia are these ones, the hyperkalemics are these, for example, the T704M is one of the common mutations, as is this one here, paramyotonia congenita. So there's classification, but there's often, you will see in the literature, patients who carry one of these mutations that look like this, or one of these mutations that look like that. So there is that kind of overlap. So the family history is very useful for us. Typically, families are aware of the illness in many and should forcefully suggest this to your pediatrician and to your neurologist, because that'll push them into testing or referring for the appropriate consultation. As you know, these are autosomal dominant inheritance, but in hypokalemics, the females often skip, and that can lead to faulty family history. As we know, this is a young onset disease, the genetic forms of it. Typically less than 5 years for hyperkalemic periodic paralysis. In some of the families with paramyotonia congenita, the grandmothers could tell which of the babies is going to get it even within a few months after their birth. I remember talking to them and saying, little Johnny is going to get it, I know it, and they were right. Hypokalemic tends to be more generalized, more severe, lasting a little bit longer, but there's clear overlap between the two types. Of course, the cardiac arrhythmia and other kinds of developmental abnormalities distinguish the ATS syndrome. I find that many patients with hyperkalemic periodic paralysis have focal attacks. I find that many of these patients, and this may be true for hypokalemic as well, I don't have enough experience to say, that even though we call them discrete episodes of attacks, many patients are almost constantly in an attack. If they're sitting still and using their arms to talk, The arms are okay, but when they get up, the legs are weak because they're resting the leg muscle. So you get this kind of a focal, constant type of attack. And this kind of leads into this situation of permanent weakness, and the point that was made that some patients with permanent weakness, some of that weakness is a transient physiological weakness that can be bettered by drugs like Keveyis, whereas the rest of the weakness is related to structural loss of muscle cells, which may be more difficult to reverse, if you will. Neuromuscular respiratory failure is uncommon. I have not had that again, but my list of patients is quite small that I follow regularly. We do see a lot of other neuromuscular patients, so there is a way to evaluate these patients if you have breathing trouble and using appropriate measurements and techniques. One can avoid intubation in many patients. So when I hear that somebody is getting intubated multiple times, I worry about it, and because certainly some people may need it, but obviously an expert evaluation in that setting is very, very important. Now, I would like to make the point that we talked about the electrical silence of the muscle cell membrane, but that can be picked up on the clinical bedside. And I think this is the key feature of periodic paralysis. Whether it's genetic or acquired, what happens is during an episode of muscle paralysis, the muscle becomes electrically silent. So here is what will happen. If you are normal and you're in the beginning of an attack, and I put an electrode on the muscle and stimulate the nerve and get this wonderful compound muscle action potential, during an evolution of the muscle weakness, the response is going to get smaller and smaller and smaller. So you're losing the electrical activity of the muscle. This is the key underlying problem in periodic paralysis. The problem is we don't catch patients during an attack and be able to do this. And if you're able to do this, that settles the diagnosis of periodic paralysis. It cannot be anything else. It can be any type, but it cannot be anything but periodic paralysis. In fact, if I put a needle in the muscle when it is very weak and low in amplitude, normal needle, many of you have experienced it, you hear that funny electrical static noise. The noise will go away because there is no electricity in the muscle. I call it the ghost muscle. So I have examined patients during attacks of paralysis, and I would put a needle in the muscle. It's a ghost muscle. It feels like nothing in there. And then it'll come back when your weakness gets better. The long exercise test, which we do in the interictal period, tries to recapitulate this. We bring a patient in, ask the patient to keep the muscle at rest after an exercise period. We often will see this, but it's not 100% sensitive. You may not pick it up in between an attack. So somebody asked about some of the differential diagnosis of periodic paralysis. If you have an episodes of paralysis where there is muscle inexcitability, and the problem is actually to document this by an expert at the time of an attack, it's often hard to do that. It is periodic paralysis. Any disorder with chronic low or even high serum potassium can present with periodic paralysis. So there are a number of kidney disorders, including some genetic disorders that were brought up yesterday like Barter's disease, Gettleman syndrome. These are renal disorders where you will see a change in the urine electrolyte pattern. And interestingly enough, all those are also ion channel mutations, but they affect the kidney rather than the muscle. And the periodic paralysis in these syndromes is because of the secondary problem with serum potassium. In hypokalemic periodic paralysis, actually, during an attack, the urinary serum potassium is actually low. It's not high, because all the potassium is going into your muscle cells. Chronic use of diuretics, chronic use of laxatives can lead to hypokalemia. We don't see barium toxicity, but it has been reported as like a suicidal or homicidal agent. Barium is in depilatory agents, for example. There are other episodic nervous system disorders that are usually clinically easily distinguishable. Episodic ataxia is episodic movement disorders. Cataplexy is associated with narcolepsy, epilepsy, etc. These can be sorted out by a neurologist without much difficulty. Gene testing is most useful in familial cases. So one of the things you want to do if the gene testing is negative, especially if the onset is a bit later in life, you need to look for acquired reasons. You may be running a low serum potassium, which can be adrenal disease, renal disease, or some of these rare genetic renal disorders. In fact, most of those renal disorders come on in early life as well. You see that not 100% of patients have established mutations. We talked about the variants of unknown significance. If clinical picture is diagnostic and you can show that the muscle cell membrane gets shut down during episodes, the VUS is likely to be a real mutation, even though it's reported as a VUS. If clinical uncertainty exists, you need more efforts to establish the clinical diagnosis more firmly. And then there are other research strategies that can be employed to figure out the variants of unknown significance. The other scenario is you have a diagnosis of periodic paralysis, but no mutation detected. The technique may miss mutations in known genes because it's not good enough. Genetic heterogeneity, that is other genes, and we talked about this, for example, the ryanodine receptor, or a disorder other than periodic paralysis. These are findings in patients with potassium channel mutations. This is myotonia, where you grip the hand and you have trouble relaxing the muscle. This prominent myotonia usually seen in paramyotonia congenita, not as much in hyperkalemic periodic paralysis. This is an example of what we call lid lag. This is often the minimum myotonia we see in hyperkalemic periodic paralysis. You look up and look down, and the lid kind of gets stuck up there. Electrical myotonia that is picked up with the needle EMG, as you can see there. I think if you have a sodium channel mutation, your phenotype, the geneticists like to use the word phenotype. Your clinical picture has to be carefully analyzed. Is it periodic paralysis? Is it a cold-sensitive syndrome? Is it a sodium channel myotonia? Because your management can be a little bit different. We have an example here of one of my patients who would come into the hospital with focal attacks of intense myotonia. The muscle will be intensely active, stuck in a position, very painful, and I don't know whether correcting a potassium or anything helped her. In fact, we tried anti-myotonic drugs rather than the routine. Her potassiums were normal at the time. I'm sorry this doesn't show well, unfortunately. This is, so what I'm showing here, if you can see it, is we begin the muscle in a normal temperature. Somewhere along the way, we cool it, and the response becomes delayed because it is cold, but it also falls off in amplitude. This is another patient. And so this is cold sensitivity. That means when you cool the muscle, the response, some of the muscle cells are becoming inexcitable. This is a rest after exercise over a period of 30 minutes. The response becomes smaller and smaller again. So this kind of phenotypic analysis often helps us to manage the patients a little bit better. And I was struck by the non-muscle symptoms, and I just wanted to be curious and look this up. So you can go to the database and show where these channels are expressed, for example, and it turns out that the potassium channel that's mutated in Anderson-Tavel is expressed widely, which goes along with the wide phenotype, that wide clinical picture, the skeletal deformities, the cardiac problems, et cetera, that you see. Whereas the calcium channel and the sodium channel are expressed predominantly in skeletal muscle, a little bit in other tissues as well. Here, for example, I think there is expression in the genitourinary system in females. So the question is, this would suggest anyway, that some of the extra muscles clinical picture we're hearing about may have a secondary origin rather than just in the mutation itself. I will briefly summarize this, but I think you folks are more familiar with this than I am, because you work out methodologies that I don't know anything about, and how you deal with some of your symptoms, because I'm not there with you every day that you get. If you're cold sensitive, keeping the muscles warm may be one way to get rid of a myotonic attack or even paralysis of a focal nature in potassium channel mutation. We talked about the mild warm-up and the warm-down yesterday. In fact, I had one slide showing the drop-off in the muscle potential. I couldn't dig it out of my folder, where I told the patient to keep on gently activating the leg. And what we saw was that we could avoid that drop-off that was present when the muscle was totally at rest. If you gently activated the muscle, the response stayed up. So gentle activity certainly helps many patients with periodic paralysis. We talk about giving potassium, usually short-acting variety for acute attacks. Carbohydrate snacks can avoid an impending hyperkalemic periodic paralysis attack. salbutamol, which is Ventolin, which is a beta agonist. It works on the adrenergic system, probably drives the potassium into the cells for hyperkalemic periodic paralysis. People brought up propranolol yesterday. I don't have any experience with propranolol, but I remember an old paper where when people could do these very intensive studies, Dr. Andy Engel from Mayo Clinic reported that if he injected a norepinephrine or adrenaline, one of the sympathetic catecholamine drugs, regionally into an arm or a leg with a patient with hypokalemic periodic paralysis, that leg will get paralyzed. He reported this. Of course, we cannot do these studies anymore. The IRB is not going to let us do those kind of studies anymore. But I do recall that there is a direct effect of these hormones, which you usually generate in response to stress. If you put out too much of those hormones, it's going to depolarize your muscle cell, make them paralyzed. The same with insulin. You can actually take a muscle cell from patients with hypokalemic periodic paralysis in a bath and squirt a little bit of insulin. That's going to paralyze it. So you can imagine when you eat carbohydrates, you're increasing your insulin level in response to that, and that probably explains these acute attacks with carbohydrate snacks, if you will, in hypokalemic periodic paralysis. The problem is the homeostasis, the precise nature in which body controls these catecholamines, insulin, sugar level, electrolyte levels. It's not going to keep it at a very constant level. And what I find in many patients is, in terms of serum potassium, each patient seems to have a sweet spot where they do well. And I'm not sure that it's easy to keep it at the sweet spot all the time. I do consider anti-myotonic agents if I think that a patient with sodium channel mutation has more myotonia than periodic paralysis. They often get into episodes of myotonia where they get very stiff, very painful. And if you don't see them during that, it's hard to figure that out. And again, I think this is things that are quite familiar with, and I won't go into that. Talked a little bit about special situations during pregnancy. There is both increase and decrease in rates of attack that different people have reported. Which also kind of dovetails into issues of anesthesia, which were brought up yesterday, so I thought I'd put it up there. And like many things in this rare disease, and I've dealt with other rare disorders where I've been part of care guideline committees where we try to develop, in many of those rare disorders, we did not have what medicine calls evidence-based recommendations. Nobody has done large-scale studies to say, this is how you need to do this. So it also, often these guidelines that we put out for these disorders have been what we call consensus-based care guidelines. So people who have taken care of these patients, experts are brought together, discuss the details, and pull together certain care guidelines. And that may be important for this group to do as well, bring people together to pull out what we call consensus-based care guidelines. And some of the common things we see with anesthesia and neuromuscular disease, obviously lung function. In many other disorders, the lung function is predictable. It predictably goes down as they get weaker. So we can tell before anesthesia and surgery, how good is it? Does it need to be managed? The problem in periodic paralysis, of course, is you can start with a normal lung function, breathing muscles before the surgery, but during the surgery you develop hypokalemia and you lose your strength. So that's a problem. So but it can be managed. Cardiac clearance with those with cardiac issues, making sure that if they have a cardiac rhythm problem, that is appropriately managed by a device. In some of the other disorders like that I take care of, like myotonic dystrophy, many of our patients have a prophylactic defibrillator and pacemaker put in, and the cardiac device has to be checked out before anesthesia and surgery. In any of these muscle disorders, particularly those that have myotonia as a part of it, when you use certain drugs like succinylcholine, which are depolarizing drugs, you may get an unusual myotonic reaction. The muscle may become intensely stiff, which the anesthesia person may not expect. And that often causes trouble with intubating and relaxing their muscles and leads to an unexpected problem in the anesthetic table. So generally, and again, there are no guidelines for this particular group of diseases, but I would say avoiding non-depolarizing drugs would be important. And the issue of malignant hyperthermia, of course, malignant hyperthermia is usually related to ryanodine receptor mutation, which is a cause of atypical periodic paralysis. So you always worry about malignant hyperthermia in any kind of muscle disorder like this. I don't know whether there's an excessive MH in this population, but anesthesia people need to be aware of your muscle disease and the potential for malignant hyperthermia. It's usually triggered by halothane type of anesthesia. May want to avoid those things. And of course, in this particular disorder, they need to watch your serum potassium and electrolytes very carefully, pre-op, intra-op, and post-op, and temperature, because again, many patients are cold sensitive. A lowered body temperature is going to make the muscle paralyzed. And the anesthesia people need to be aware of it, because during surgery, often your body temperature will go down. So they need to maintain the body temperature, will all be important. And I want to thank you for your patience, and I'm happy to be in here and happy to help in any way I can. Thank you.
That was really excellent overview. Are there any questions for Dr. Subramani? I'm sure there's a bunch. I have one also, and maybe while Steve is here too. There are some folks who, get paralyzed, and I believe clinically have periodic paralysis, and they go down, sometimes suddenly, and they're paralyzed, but then they twitch or jerk, which doesn't make any sense at all, because if you're paralyzed, you shouldn't be able to twitch. You should be paralyzed, but yet, they're twitching. Do you have any hypothesis, comment?
No. Certainly the sodium channel mutations seem to swing between excess muscle activity and little muscle activity. That doesn't seem to happen in the hypokalemic periodic paralysis, because you don't usually see myotonia. But with regard to that particular symptom, I have no clue.
Okay, I just throw it out there.
Okay, what I wanted to ask was, I like to do a lot of exercise, but I know I shouldn't overdo it, but the exercises that I'm trying to do to keep muscle with the periodic paralysis, is it helping to keep my muscles from just atrophying and eventually I'm not going to have any muscle there? Or is it where the exercises that I'm doing may prevent it from happening?
Good. Dr. Levitt, can you repeat that question?
Yeah. So I guess the idea is that if you don't exercise, your muscles are going to atrophy. And if you exercise, you're going to get paralyzed and have your muscles atrophy. How do you keep physically...
Right.
Is the exercise helping or is the exercise harming? How do you keep physically fit with this disease?
Difficult question. Of course, in general, with many muscle diseases, not specifically with periodic paralysis, we say do not exercise to a point of crampy, achy muscle. Now, having said that, I think the periodic paralysis, just thinking about it, a unique situation. That again, going back to my comment about serum electrolytes, there may be a sweet spot of exercise for different people, because when you activate your muscle, you are pulling that sodium in and pushing the potassium out. You're getting these changes all the time, and you do have a leaky sodium channel, and it's very likely that the permanent weakness that you have results from the excess leak of sodium into the muscle cell and secondary problems that happen within the muscle cell. So you could argue, and again, there is no way for me to give you a judgment on this regard. We also know that mild warm-up keeps many patients from becoming significantly weak. So I would say a moderate amount of exercise, maybe more frequent, not intense in short periods of time, may be a useful thing rather than, like many of us do, go to the gym for 1 hour and sit down for the rest of the time. Others may have opinions on this. I see some hands maybe. And so that's just a guesswork on my part.
it's great. There's a lot of hands, so we'll get to everyone. Just write down the question if you forget.
Thank you for your information this morning. My wife was diagnosed with hypo in '94, has been on Diamox and potassium since that time. Two questions. One is about 10 years ago, she developed a chronic cough that has been almost as debilitating as the paralysis itself. So I wondered if you had any thoughts on that, or if anyone else has experienced anything like that. She does not cough during an episode, so it goes away during a paralysis episode.
Does she have a sodium channel or calcium channel mutation?
It was a clinical diagnosis.
Okay.
So we
Yeah.
have she's not been tested yet.
I mean, as a person having dealt with a lot of genetic disorders, I keep an open mind because we sometimes find a clinical thing that we did not expect after we find the mutation. I don't know the answer again. I mean, there are, of course, the common things that general physicians think about, postnasal drip and other types of lung disorders and exposure to allergens and smoke. If those are excluded, there are certain medications that can give you chronic cough. You need to be sure that you're not on some medicines that are inducing that cough. Reflux from the stomach can give you a cough. So I'm just talking about things that are not part of the periodic paralysis. I was intrigued by a report with one of the sodium channel mutations. There was a patient with maybe more than one, what they call fatal neonatal laryngospasm. There was a very severe phenotype in a baby where the baby developed spasm of the throat, for example, which was made the patient very sick, and I don't remember that particular mutation. So is it possible that some of these mutations have things like, when I look through that expression pattern in various tissues, you do see a minimal expression in other tissues other than muscle. Maybe that's enough to change something in the bronchial tree. I don't know. And no matter what, this will obviously need to be dealt with in a symptomatic fashion.
Okay. The second question I have was on the ability to measure potassium at home. Has there been any progress made in that area?
I don't know. Dr. Levitt may know
Yeah,
better
but
than I do.
that we still have that iStat thing that is used in hospital settings, in surgical settings, but so far not great. I'm not a big fan of the home ion meters that were meant to test, water or like soil, and you spit in it or put your blood in it and measure potassium. I think that's very dangerous to use because it's not calibrated, it's not FDA approved, and if you get a wrong reading and act upon it, it's kind of dangerous. People do that at their own risk, but so basically no, the short answer.
It was about the previous question about how can you have jerking if you're paralyzed. I found that before I got treatment for paralytic paralysis, I had myoclonic jerking in a severe degree. I had, just an example, now I only have it when I have an attack and in a smaller degree, and I found out it has a lot to do with the strength of breathing. So 2 days ago I had an attack out here, and I quit breathing completely when I have an attack often, and at one point I was totally gone. There was no reflexes. As I started getting better, I started jerking, and there was a couple of paramedics there, and I said, "It's okay, it's a good sign," because that's when my muscles start working again. And I've seen this in the hospital. When I've been completely paralyzed, I have actually, they've actually proved I have no reflexes, but it might only be for a minute or two. And then when they try again, I have a little bit of reflex, and that's when the jerking starts for me. So I didn't know how bad my breathing problems were until I was assessed. I've been fortunate enough to have Dr. Weber in my case, so he suggested I go to a respiratory doctor, and found out that even on a good day, my, what's it called, the CO2, what is that in Danish, or English, sorry? CO2, that it was so high that I should have maybe been on the way to a coma. And actually, I was walking around breathing. They don't understand that I could walk around with so high CO2. My oxygen level was like 92, so they didn't understand that. But it's definitely the jerking. On top of that, I also had a D vitamin deficiency and a magnesium deficiency. I only get it now, the jerking, when I'm in a bad attack and I don't breathe well.
That's interesting. That probably gives people some ideas. I mean, maybe the muscles are flipping in and out of complete inexcitability.
I just had a comment about exercise. I'm an exercise physiologist, and we've, in the lab that I was working in, we've done some research with spinal cord injury patients and passive movement. So sometimes even if you are not physically able to move, having a caretaker, spouse, child, whatever it may be, there's still benefits that you can get to circulate blood flow and things like that to the muscle that can help. Just with overall blood flow and all that sort of stuff, and helping to clear out some of the metabolites that build up, even if you're not physically able to exercise. And then I've also personally worked with a number of people with different chronic and rare diseases as like kind of helping them train and exercise. And the main recommendations at this point are, if you have a muscle condition, you don't work out to the point of muscle breakdown. Like a lot of people would say to do to build muscle. You work out up until you would get to that point, because you're going to get the benefit of movement and maintaining without that breakdown of the muscle that is going to be detrimental in the long run.
Like weightlifting versus, walking.
Yeah, so like if you wanted to do like weightlifting, it would be lighter weights. You're talking more kind of the muscular endurance, not looking for hypertrophy or building actual muscle, bodybuilding. Cardio exercise or stuff that you're working below that threshold of I'm gonna die sort of thing, you want to stay well under that. And I'd be happy to talk to anybody if you have any questions. I don't know everything. I'm newer to periodic paralysis. I've only been diagnosed for a year and a half, but I've had symptoms for a while, and I've worked with a lot of people with different types of chronic conditions. And so I have the black poodle. Come say hi if you have any questions.
Very cute. Been petting him.
Hi, our questions come based on breathing episodes, or breathing difficulty due to full body paralysis. My husband didn't used to have that when it first started, and now he does, and it seems to be getting worse. His breathing gets very, very shallow and it slows down. My concern is, does anybody else have this situation? Does it continue to get worse? Yesterday after the conference, we were talking to some of the paramedics, and one paramedic brought up, well, does he have a gag reflex? And I don't know, I don't stick my finger down his throat when he's paralyzed. But he said if he's conscious, which they are, we are, and he has a gag reflex, doing like emergency breathing for him won't work because has that gag reflex. So I just am curious if anybody else has had any experience with that. And then also, since his breathing has gotten more affected, when he starts coming out of it, he does have his right arm that does twitch now as he's recovering.
So, I mean, muscle weakness and respiratory, what we call restrictive lung disease, is quite common in many progressive muscle disorders. Now, again, periodic paralysis is unique because in other disorders you have a predictable slow decline in diaphragm function, in the chest wall function, depending on what the disease is. And it's a little bit easier to make recommendations. We follow the pulmonary function. In many disorders, we have a poor cough, so we measure something called peak expiratory cough flow to see how good a mechanism cough is, because it gives us an idea how forceful the cough is. And many of our patients, actually, the cough may become depressed before their respiratory muscles lose their strength. and we make recommendations of how to keep your chest clear of secretions, because with these kind of symptoms that you're talking about, there are a couple of risks. One is higher risk for chest infections. If you get a little cold, pneumonia will be more easy to occur if you're not clearing your secretions and if you don't have a good cough. And of course, if you end up having a lot of respiratory muscle weakness, typically the carbon dioxide level goes up, as somebody just pointed out, before the oxygen level goes down, makes you tired, you have poor sleep. A lot of times we recommend sleep studies now to see what they're doing at night, because some of these patients with muscle weakness in the chest wall, the initial problem is with sleep. They will desaturate, their oxygen level will go down more than normally if you have respiratory muscle weakness in a sleep study. And in some places we also can monitor the carbon dioxide, because CO2 tends to go up during the night. You wake up with a morning headache and have excessive tiredness during the day. So those are some of the symptoms of neuromuscular respiratory deficiency. The problem that happens with periodic paralysis is, of course, the intense swing. Some day you may be totally normal, other days you're up and down. Then, of course, then you have the progressive patients who have progressive weakness who can fit into the mold that I just talked about. So if it's a periodic, comes and goes sort of thing, I don't know the best answer, but again, a good pulmonologist or a neuromuscular physicians increasingly take care of the lung issues that happen in muscle diseases. We have, for example, the capability of measuring the respiratory function in our clinic. We do that as a routine when patients come to see me to see what their breathing muscles are like. Pulmonologists will be able to do other things like measuring carbon dioxide and oxygen. We sometimes have home-based oximetry to see what happens to oxygen at night. So there are lots of things available in the absence of a direct treatment to improve everything in a genetic disease like this, and those can be managed. And there are increasing non-invasive techniques to manage respiratory failure without intubation or tracheostomy. So these are available, and it's the important thing is to find the right group of people who can help you with those, and see if they cannot understand the symptoms and do the right thing.
Yeah, there's a lot of commentary on this. I'm going to try to get to everybody.
I have the same problem, but in a very severe way if I am awake. I do not have it when I sleep, the apnea, but I have apnea when I'm awake. And I discovered something, I get medical exams for it soon. There are medications to, what is the name of it? Stimulate the breathing muscles from the brain, like Mestinon, Prozac, 3.4 DAP does that also. But now I discovered some food issues for me. That's not a problem in everyone I know. But yesterday there was a man, and he said, when I'm very weak, I take a cold shower. I don't know if he's still here. No? Oh, but I have that as well. So if I breathe I have very difficulty to breathe, then I have to take a cold shower and it's okay. But if I warm up, my body temperature is always a little high, then the breathing problem starts again. So there's more than only periodic paralysis, but congenital myasthenia syndrome does give the same problems, and porphyria is something they will look into for me and give these problems even more. So.
And then what do you think about the role of like having a home pulse oximeter and maybe even like a bag mask if someone is very frequently, going down and has very shallow breathing and stuff like this? Is that a...
Right. I mean, if there's a consistent decrease in desaturation during the night, for example, or CO2 rise, many of our other neuromuscular patients are on non-invasive ventilation at night. Depending on what kind of breathing abnormalities they have, it can be a CPAP or a BiPAP, something called Trilogy. These are machines, a lot of people are using it anyway without neuromuscular disease because they have obstructive sleep apnea. I've got one in my room, and I cannot sleep without it. But there are many of these machines available that will help you with that. It's not been our experience with any of the muscular disorders that, except for some very bad ones like Duchenne and ALS, that these patients need daytime assistance. Some of them do, but some of the really severe neuromuscular respiratory failure may extend the time from night to day. So yes, appropriate evaluation, understanding what is happening, is it obstructive, is there sleep apnea, is it neuromuscular respiratory failure, will allow for proper management. There is also, for example, we have a group of pulmonary physical therapy research faculty, a couple of them, that are trying to understand the role of respiratory exercise and breathing exercise in improving pulmonary function and swallowing function. And they come up with innovative methodologies to try and help patients with these kind of problems because, the role of non-pharmacological intervention in many of these disorders is quite important. And the thing I like about non-pharmacological intervention, you don't have side effects. So I'm very much in line with that. If we can help breathing with breathing exercise, cough exercise, chest percussion, all those things. So we have pulmonary physical therapy people who work on those with some of our patients to try and help them. Again, it's a very individualized decision that you work out with an expert if you can.
Our family has paramyotonia congenita. I have a 34-year-old daughter who has respiratory issues during episodes.
Mm.
She never started the full body episodes till she was in her 20s. And as time went on, it did start affecting her respiratory. And in fact, it seems to attack her respiratory first when she goes into an episode. She's seen many, many doctors. She's spent the last few years basically in the hospital. She does not have any lung disease. It's just during the episodes, her oxygen can go below 80. She feels everything in her diaphragm, in her throat muscles, and until she comes out of it, that's the way it is.
So
yes, she's been intubated many times, and I can stand there and say, please don't intubate her, and they'll say, she's not breathing on her own after they've begged her for many minutes.
So this is you have a sodium channel mutation?
Yes, SCN4A,
Yeah.
T1313M.
Yeah. And again, so this is a paralytic episode rather than a myotonic episode, I'm assuming, or it's hard to tell sometimes. Is it muscle stiffening up or is it muscle becoming weaker? Could they?
I'd say it was both, everything.
Right.
Yeah.
Well, no matter what, I think, again, in this situation, I would apply what we do with other similar disorders, and she okay?
Are the paramedic guys here? Or?
So to continue my comments about acute problems, generally in many of these patients, we will monitor their respiration. There are certain numbers that we generate, like vital capacity, negative inspiratory force, blood gases, and there are certain guidelines people generally follow. Say if the numbers get below a certain level, you worry that they will need to be intubated. So those guidelines generally come from not periodic paralysis, from other disorders. So muscle weakness leading to respiratory failure, there are these guidelines that have been developed from other disorders. For example, if you look at patients with myasthenia gravis and Guillain-Barré syndrome, 1 in 5 of those patients end up needing to be on a ventilator at some point in the course of the illness. So there are some guidelines that were developed because these patients gradually decline in front of your eyes in the hospital. So there are those guidelines that we kind of tend to follow in any patient with muscle weakness, a negative inspiratory force of minus 25. If you're not going to generate that degree of inspiratory force, you need to be in an ICU. 22 per kilogram or something like that, vital capacity, ml per kilogram, then, when I was younger in training, many of these patients, not periodic paralysis, such as other muscle patients, would often get intubated in an emergency situation, and we avoid that. We do prophylaxis, but only if it's needed. And the non-invasive ventilators have become quite useful, even in many of our patients avoid, even with myasthenia gravis, by using these non-invasive machines. So what Dr. Levitt was talking about, having a mask at home, that's kind of these machines basically put a mask on your face and be able to generate pressure. So I don't know what to say about that particular patient who has repeated episodes of significant respiratory problems, other than being able to manage that and also at the same time manage their attack with lowering the potassium, salbutamol, whatever, and glucose infusion, whatever it takes to bring the potassium down and allow the paralysis to get better. So I'll stop there with that. All right, thank you very much.
Incidentally, this moment of silence is dedicated to the Orlando Public Library. Ann Belka is a licensed mental health counselor. She has a BA in counseling from Marshall University, Huntington, West Virginia, and a MA in counseling, Columbia International University in Columbia, South Carolina. Among other skills, she is trained in accelerated resolution therapy for trauma treatment. Ann is also a U.S. Navy veteran with 14 years active duty as a supply chief. Her work experience includes work in several varied mental health settings: a domestic violence shelter, Army inpatient psychiatric unit, outpatient clinic for children and adolescents, private practices, overseas and domestic missionary locations, and church counseling centers. Ann believes that the relationship between a counselor and a client is a place where mutual respect, compassion, and safety create a place for learning, starting over, being accepted, and in growth. Along with Ann sharing the stage is Amy Schumann, who has more than 25 years professional experience working in clinical, administrative, research, academic, and group social work. She holds the credential Diplomate in Clinical Social Work through the NASW. She specializes in treating trauma, anxiety, abuse, and issues related to sexual orientation and gender. She's also a master therapist and lead trainer in accelerated resolution therapy since 2009. As a researcher and research assistant, Amy is a co-author of several study publications under the leadership of principal investigator Dr. Kevin Kipp. She is lead author in a pending textbook chapter for graduate studies in psychological counseling. Pretty decent credentials for both. Please welcome Ann Belka and Amy Schumann.
Thank you, Jeff. Good morning, everybody. There was somebody here the other day who said something about, I am standing up, and I think that's definitely the message for me today. So I am Ann Belke, and as you heard, I've had a little bit of experience in counseling here. Started my bachelor's degree back in 1994. I've been doing this stuff ever since. I absolutely love it, and it drives me crazy, but it's really, really good stuff. The one thing that I really love is to work with clients who allow an opportunity for learning and growth, and I see that comes to pass and comes to fruition. When we talk about periodic paralysis, how did I get connected with PPA? Well, Linda asked me to come and to talk today about PPA as a result of having clients who have PPA. I have a couple of clients on my caseload that have PP. And what happens with that with me is the clients that I see have struggled with several conditions that we've been able to help with. The ones that you see on the screen, not all of these at all times, obviously, but back and forth through what they go through, not only with episodes and trying to manage their condition, their physical condition, but also manage their mental health conditions. And there's clear evidence, we know, that there is a mind-body connection there. When we activate the autonomic nervous system in a fight, flight, or freeze mode, there's definitely a physiological response. And the physiological response can exacerbate the mental response or the emotional, psychological response. And then these things will absolutely wreak havoc together. And so these issues can be effectively treated by licensed mental health counselors, social workers, psychologists, and so forth. And I would really encourage you to consider this part of your health care, this part of your life. The doctors that are here today, I want to thank you for the passionate approach that you take to this particular condition. I know that people here are very grateful, and certainly I am as well. And I know that it's difficult to just plow every day looking for answers and doing research. And we really appreciate the dedication that you have committed to this issue. In that, I would also like to say that as I present this information today, those of you who are physicians, I would ask that you would consider that when your clients and your patients are coming to see you, that perhaps check with them to see how they're doing outside of their physical condition. And if there's a referral that's necessary or that would be really convenient, prudent, and very fruitful, that you would make those referrals so that people could get assistance with some of these other issues. We've just heard a lot about anxiety, and we've talked a lot about anxiety. And when my clients that have PP are in my office, we work with anxiety a lot. And we also talk about trauma. And this is one of the things that Linda wanted me to talk about, because it's very traumatic. Even the questions that you just asked and the responses you receive indicate to me that this is a harrowing situation repeatedly over time. And my heart is in that place where, as this is difficult for you, there is something that you can do in this type of support, not only to take care of your physical well-being in as much as you're able, but also to take care of this part of your life as well. So, as we see, the clinical definition of post-traumatic stress disorder is one of the things that I'm going to present today, so that if those symptoms are very familiar to you and it sounds like maybe you need to get checked out, then you can make a choice to do that. We're going to look at a criteria for clinical diagnosis of PTSD. We're also going to take look at 3 treatment options that are shown to be highly effective in treating trauma. Now, post-traumatic stress disorder is a psychiatric disorder that can occur in people who have experienced or witnessed a traumatic event, such as natural disaster, serious accident, terrorist or combat, rape, other violent personal assaults. This is a definition that's provided to us by the American Psychiatric Association. And where do we get that definition? Then what we see is this comes from the DSM-5, which is the Diagnostic and Statistical Manual, the 5th edition, developed by the American Psychiatric Association. And it's used by healthcare professionals in the US and most other countries and to determine the mental diagnoses and in order to create treatment plans that are appropriate to the diagnoses. It provides a common vocabulary for professionals, and it establishes standards for mental health diagnoses. PTSD is categorized as trauma and stress related, and it's diagnosed if symptoms are present more than a month, diagnosed if symptoms of impairment or stress are present across areas of life, work, school, home, personal, social relationships and settings. The diagnosis or the dissociative reactions recurrent distressing trauma-related dreams, dissociative reactions, for example, flashbacks, reliving or versus remembering something, numbing out, feeling disconnected, feeling almost like an out-of-body type of experience, and that things are not real. Memory lapses or difficulty focusing are also common in PTSD. Intense and prolonged, longer than a month, distress after a traumatic exposure, and significant physical reactivity after exposure to trauma-related stimuli, for example, sweating, shaking, heart racing, and feeling smothery. And if you think about some of these symptoms that we're talking about here, many of them you have described on a physical plane today as a result of your conditions. And those of you who are caretakers, those of you that have seen your loved one go through these things, this can also apply to you as well. And so keep that in mind as we go along. Avoidance, at least one of the following 2 symptoms: persistent avoidance of thoughts and memories, for example, isolating, sleeping too much or too little, self-medicating, occupying time with TV, videos, video games, not engaging in things you used to enjoy like hobbies, travel, visiting with friends or family, social activities, volunteering, and so forth. Persistent avoidance is another one of external reminders. For example, a certain place you really don't want to go back to, colors, smells, sounds, activities, and situations. The negative changes in cognition and mood, thinking and feeling, are another criteria. And of these, at least 2 of these symptoms have to be present for a clinical diagnosis. Dissociative amnesia of the traumatic event. I can't remember. I know that it happened. I know something happened, but I can't remember it or remember the details. Persistent negative expectations, overall sense of pessimism. I just don't feel like anything good is ever going to happen again. So persistent distorted blame of self or others about the traumatic events. I see many people with trauma have this as really a strong symptom with or without PTSD full diagnosis, where they really take on an inappropriate blame or guilt for having, for example, an episode, or they feel guilty about their loved one who's trying to take care of them, and this causes a lot of stress. So a persistent negative emotional state is another one, feeling down or angry, anxious. I talked with somebody earlier today who said, I can't tell you how anxious I've been. Another person said, I just stay angry, just agitated. I'm always on edge, and it's really hard to deal with. And if you think it's hard to deal with for me, you should talk to my family and my loved ones and the people who care for me. So diminished interest and participation in significant activities, feeling of being detached or estranged from others, persistent inability to experience positive emotions. So a last category here is alterations in arousal and reactivity. At least two of these have to be present for a clinical diagnosis of PTSD. Irritable behavior or angry outbursts. We just talked a little bit about that. Irritability. Reckless or defensive, self-destructive behavior. Hypervigilance. Extreme caution. Checking, and rechecking something. Exaggerated startle responses. If some slight noise just makes you jump out of your skin, this is an exaggerated startle response. Problems with concentration, focus. Sleep disturbance. Now, PTSD is a result of medical emergencies. After I started treating someone with PP, I began to wonder about this and what the incident is of trauma, actually a trauma diagnosis with like PTSD. What happens with medical conditions like PP? Obviously, very little, if any, research out there on this, and what I did find was certainly not about PP, but it was about other things. And the studies that I reviewed specifically were based on specific medical procedures or hospital stays. For example, PTSD was diagnosed after heart attacks, medical interventions, surgical or diagnostic procedures. And all the studies I reviewed showed significant numbers of diagnoses of PTSD after traumatic medical intervention in an average of 25 to 30% of the people that had these experiences. So depending on the type of intervention, these percentages increase proportionately with the intensity of the situation as it's perceived by the person who is fearing life or death. So PTSD and periodic paralysis. So those 5 symptom clusters, here are some things I've seen in my clients. Exposure to traumatizing events, either a PP episode itself or medical intervention when someone has to be let's say, transported in an ambulance. One of the first things they want to do, EMTs are trained most often to start an IV. So what's in an IV? Ringer's lactate and normal saline. Usually those things are not great with PP. Is that right? This is what I'm noticing and learning from you and from the doctors. Intrusive symptoms, thoughts, dreams, flashbacks of either episodes or the medical interventions that they've experienced. Avoidance, avoiding places, sounds, sights, and smells that remind you of the trauma. I talked with one person who said they didn't come to this conference because their anxiety was so high that they had a panic attack. I think that's a significant avoidance that's directly related to what she had gone through in some other situations, and that was medical treatment. And she knew that everybody that was here was going to be talking about the medical aspect and the pharmacological aspects of this condition. So her anxiety was extremely high. So there are negative changes in thinking and mood, like depression, anxiety, irritability, anger, difficulty focusing, change in arousal and reactivity, easily started, jumpy, inordinate fears, and excessive worry. And I want you to remember, I'll go back to this slide just one moment. I want you to remember that those of you who are in this room who are caring for a loved one, a friend, a relative who has PP, all of these symptoms and categories of symptoms can also lead to trauma for you as well, even if you've never had an episode. Many of you are related to the person that you're here with, or other family members that you have here, and I realize that many of you in the same family have PP, and so I see both the individual and I also see family members at times when that's appropriate. Evidence-based treatment options for PTSD. One of the top and probably gold standard treatment protocols for PTSD has been EMDR, which is eye movement desensitization and reprocessing. It was started in 1987. Historically, this has been VA's really go-to preferred treatment for combat PTSD. Believed to be that it is effective through the use of eye movements that stimulate, or rather that simulate, REM sleep. And when you think about REM sleep, we're talking about a sleep mode that is relaxed and the mind is as open and working and active at the same time as being relaxed. And so this is used in EMDR to reprocess traumatic experiences when all of that anger, all of that anxiety and other symptoms are coming up. An average is 10 to 12 sessions with EMDR to address trauma symptoms and manage them. The next one is cognitive processing. This has been a protocol that's been recognized in the mental health field since 1989, a couple of years after EMDR. It's a form of cognitive behavioral therapy in which focuses on changing the way clients think and behave in order to change the way they feel and react or interact. And it's based on the concept that symptoms are caused by the way a client thinks about the trauma. And in this one, the average is 12 sessions for adequate treatment. One of the new protocols that's out here is a new treatment for PTSD. When we say new, it's been used since 2008, accelerated resolution therapy. And the this one in particular uses several treatment approaches that are combined, including the rapid eye movement. And it changes the way stress-inducing memories are stored in the brain and thereby reduces or eliminates the negative physical and emotional effects of the trauma response. 1 to 3 sessions. This is what intrigued me so much about this particular approach to trauma. As a therapist, I would see clients coming to my office, and often they would be traumatized somewhere in their past. And when we were trying to work on their current life, those things would be activated, triggered, we say, and their response in some of these symptoms that we're talking about today would be vivid and visceral in the moment. And we would have to stop and deal with that and then come back to whatever we were dealing with in terms of therapy in the moment. So this would be a very long process at that time. But with one session, I've seen amazing, absolutely amazing results. I had a gentleman who was 72 years old. He was a Vietnam combat vet. He went to Vietnam when he was 19 years old. He was a combat medic in a field hospital, and he stayed there 2 years. I cannot imagine what that man suffered through in those 2 years, but I really can't imagine what he's suffered through ever since. He's been to a number of different types of treatment, pharmacological treatment as well, and his brother-in-law told him about me. He came to me, we sat down and talked through why he wanted the treatment, what he wanted to gain from the treatment, and we sat and actually went through this protocol together. With one session of him thinking about, only thinking about, not even talking about what happened to him, and going through a verbal protocol with him in which I would direct him what to do next and next and next. One session, within an hour and a half, this gentleman went home, came back the following week, and he said, "Ann, I don't know how that worked, but I've had the best 3 nights of sleep that I've had since I was a 19-year-old boy and went to Vietnam." His wife said, "I don't understand it either." This man is angry most of the time or extremely irritable, and that's gone. And I can only say to you, this works the same way for any trauma, and I've seen it over and over and over again in my office. Accelerated resolution therapy is really straightforward. It uses these eye movements, and those are very soothing, actually. And it's a technique that allows clients to change the way in which the negative images are stored in the brain. It moves traumatic memories from short-term memory to long-term past memories, and it works in part by using those rapid eye movements. The end result is that the trauma and the difficult life experiences that result from it will no longer trigger those strong emotions and those physical reactions. Importantly, though, we got to say clients do not even have to talk about what happened to them. It is not necessary. So this is really an exciting development in trauma treatment and resolution. What is ART not? It's not hypnotherapy. Nobody is hypnotized in my office. It does not create amnesia. You will remember what happened. You just won't have the same reactions that you had in the trauma responses. It does not change a person's personality. It does not replace counseling for relational challenges or for healing or changing an organic or physical condition in the brain, and I would also say certainly in the body, in the rest of the body. ART is not suitable for those who have active suicidal or homicidal ideation. Though once a person is stabilized with those thoughts, then they can consider ART. If you consider ART treatment for the trauma that you've been through, if that is you, I would highly recommend, if you are on medication, to talk to your doctors before you adjust or change or discontinue any kind of medication. I've had clients say, if I have an ART session or 2 or 3 and my trauma symptoms are gone, should I go off my medication? First off, I'm not a physician and I cannot advise someone to change their medication in any way. But I can certainly admonish that person, please, whatever you do, don't change your medication without talking to your doctor. You and your doctor decide that together. If that's to be changed, make sure that it's changed in a safe way. Psychotropic medications in particular can bring about homicidal or suicidal ideation if they are abruptly discontinued, or they can exacerbate the very conditions that they're designed to treat and to help to relieve or manage. This treatment, ART, can be used to treat several types of mental health conditions, not just trauma. It can be used for anxiety, panic, depression, addiction, a long, long, long list now that we are seeing more and more in anecdotal research, and also the VA now has a 3-year study at the Cincinnati Department of Veterans Affairs Medical Hospital there, that they are examining ART head-to-head against other types of treatment protocols for trauma, and we will know more and more about this particular approach as time goes on. Amy is also going to talk with us this morning briefly about research in ART. Whatever type of treatment you decide to consider, physical or mental, I highly encourage you to do your own research. I see and hear what all of you are doing to try to understand your physical condition and many conditions, and I'm absolutely impressed, just thrilled to death that this is what you do. And I know that it's come out of necessity and desperation at times, but it is absolutely your body, and it is up to you what you do with it. I have a couple of websites. I will email those over to Linda, and she will have those to shotgun out an email to you, and some other resources that I'll have available for you as well. This is Amy Schumann that was introduced to you earlier. Let Amy talk to you about research. Amy?
Thank you, Ann. So as Ann said, I'm here just to fill in a little bit about the research to give a little more credibility to accelerated resolution therapy, which is a therapy that's different from what people usually imagine or participate in when they're engaged in therapy. I'll just quickly say one part that we would spend a lot more time on if we had more time. There's another piece of what we now know about the brain that we utilize when we do accelerated resolution therapy. Okay. So I'm just going to quickly mention this to you, and if you jot it down and you're interested in learning more about memory, emotionally based memory in the brain, you may want to research. As a matter of fact, there's a PBS Nova special called Memory Hackers, which you can get on YouTube for free. And it's absolutely fascinating, telling you so much about how memory works in the brain. But there's a specific phenomenon that we capitalize on when we do accelerated resolution therapy. It's called memory reconsolidation. And in one sentence, I'll just say to you, whenever anybody recalls an emotionally based memory, when they bring up all the different parts of the brain together to recall all of the different senses and aspects of that memory becomes malleable. I use a metaphor and I tell people, think of it as the cement gets wet. And think about how you could put your hand in that cement and make an impression. While we use the eye movements, we take advantage of memory reconsolidation. When the window opens, it begins when the person first recalls the memory, and it lasts for 6 hours. So we have wet cement in that memory for 6 hours, and during that time, we're inviting the client to imagine any visualizations that would feel better to them, to implant as the director of the movie of the memory. So first we have them go through with the eye movements and watch the movie of the memory that illustrates the problem that they're working on. And finally, we tell them to do a director's cut. As Ann said, we're not brainwashing or hypnotizing. The person could still tell you all of the facts about that memory after they engage in art, as we call it. But the images that comes up in their mind's eye as they talk about that situation will be the new images that they've put into that wet cement when they go through that session of art. And when they remember it a day later, 2 days later, one of my kids was the first person I tried this with when I was trained, which you're not supposed to do. But she told me she had a memory of a friend betraying her. So in November of 2009, when I started to do art, I had her do art with this memory of her friend betraying her. So that was, 11, I'm not good at math, 11 years ago, when I ask her still to this day, when you think about that memory, how do you see it? She still sees the new images that she put in. It was in a coffee shop, and she added golden light filling the room. She added her favorite song playing, and they were sharing a carrot cake cupcake, and she added making the carrot cake really big. She loved carrot cake. So those all brought up the affective states that go along with those new images. So while she could tell you the facts of the actual memory, she would be enjoying these new images that she put into the wet cement during that session, and it stuck 10 years later. So now I'm going to acknowledge Dr. Colonel Charles Hogue. If it wasn't for him, then we wouldn't be here talking to you about art. In about 2012, he read an article that was published in Military Medicine. As an Army colonel, he had access to that and read it religiously, and he saw the article that Dr. Kevin Kipp had published in the article about art. He was so intrigued by what he read because he's the person in military that is the foremost expert in treating military trauma, so much so that he's the most cited person in the world when it has to do with military trauma. And he wrote a book called Once a Warrior, Always a Warrior. And by the way, you're going to hear us talk a lot about military, but please don't think that that means that this therapy is just for military. It just so happens that the windows and doors that opened for us and the money for research that came about was because, as we know, so many people in the military are suffering from PTSD. But this is easily generalized to all of our population. So Charles Hogue wrote an article specifically about 5 components that must be in place in order for therapy to be considered to be credible for treating PTSD, and art meets all of those criteria. This is Dr. Kevin Kipp, and now I'm just going to bring you through a few slides to give you the research and the highlights of the research that's been done so far. Since this is a newer therapy and because it's so hard to get money for research, we go along the best we can, and there's been one major study with a randomized control trial. And the second study that Ann mentioned that's happening at the University of Cincinnati is past the halfway point in this 3-year study that compares ART to a tried and true certified therapy for military trauma called CPT, Cognitive Processing Therapy. Dr. Kate Shard, who is one of the founders of CPT, is running the study with her veterans up there against ART. So it's going to be so interesting to see how ART fares against this tried and true therapy. I just put this up if you want to take a picture of it. I'm going to put it up at the end too. Here's a lot of the articles that have been written about ART. But as you may know, if you're into research, if you just go to Google Scholar, if you put the keywords in accelerated resolution therapy, PTSD, then you'll find all of the articles, and they're all downloadable right from Google Scholar. Okay, I also want to mention that even though there aren't a lot of studies conducted so far, Kevin Kipp's studies were done so well that the National Registry of Evidence-Based Programs and Practices did certify ART in 2015 as evidence-based. Some of you may know, and many of you probably don't know, that this particular program at the federal level no longer exists. In January it was abolished, and there's a different way that the government is going through giving information about how to find a credible therapy. But still, I think it's important to know that in 2015, when the program did exist, accelerated resolution therapy was determined to be evidence-based. The green check marks tell you what was found to be certified as evidence-based, and the yellow check marks tell you what looked promising, but more study is needed to bring it up to the level of the green check marks. Okay, here comes the fun part. So here's the sample for that big study that I told you about with the randomized control trial, and the control group was an attention control group. We had 57 people enrolled in the study. 29 were randomly assigned right away to the ART regimen. In the control condition, 28 were assigned to the intention control regimen. That is, they were offered 2 sessions of interaction with either LA fitness counselor or a career counselor, where they could set goals for either career or fitness. We thought this would be desirable to the veteran and active duty members that comprise these 57 people. The mean age, you can see, is about 40, mostly male. And the top red arrow shows you that about 40% were on military or veteran disability for PTSD or other mental health problems. So this tells you that these people who came in for the study, 40% of them were earning their living, perhaps supporting their family with disability money, and yet they were so uncomfortable with their PTSD, they were willing to try to get better and maybe risk losing that form of income. Of course, if they do get better, then they're going to be able to get a job, which is what we hope and want. But if you can see how that would be very scary for someone who's relying on that income. And yet we see 40% who came into the study did so while they were on the disability. And the second arrow points to the fact that most of these people had what we would call unretractable PTSD. It's not someone who just had one episode and that was bothering them. They probably had many years of compounded problems and not just PTSD that I'll show you in the next slide or so. But they definitely were suffering from PTSD for quite some time and tried other therapies before they finally came to this trial of ART. If you look at the bottom row going across, you'll see that 93% of the participants met the criteria for PTSD. I'm going to be talking about in these slides forward a questionnaire called the PCLM. That stands for the PTSD Checklist for Military. There exists a PCLM for military and a PCLC for civilians. And also because this study is a few years old, the PCLC and M, what it does is it asks questions that go right along with those criteria that Ann showed you, but from the previous DSM, the DSM-4. And when the person answers those questions, that's how it's determined whether or not they seem to meet the level where they may be diagnosed with PTSD. So it's not a diagnostic tool per se, but it's an indication that the person is aligning with the criteria that Ann showed you. Let's look at the main results. Each vertical line represents a veteran or service member in the study and their response on the PTS checklist. That lower horizontal line represents a 10-point reduction, which has been suggested to be the metric to indicate statistically and clinically meaningful change. So at that 10-point lower line, you can see whoever met that bar is highlighted in green here. You'll notice on the left in the ART group, the overwhelming majority had a drop at or below the 10-point cutoff. And notice on the right in the control group, a couple had a 10-point drop and a few went in the wrong direction, which you can see going up in red. And when you look at the comparative means between the two groups, you see 17.2 drop in ART compared to 2 points in the control group. This is a very substantial difference, very highly significant. Okay, so this is the only other very busy slide, I think, that I'll be showing you. But you can see here, if you look down on the left, the comorbidities that show the same pattern held true. Those who were treated with ART showed a much better response on the comorbidities for depression, for anxiety, and for sleep. One surprising result had to do with the pain that the veterans had. A lot of them had combat experience, and on a 0 to 10 scale, 4 was considered to be the cutoff for significant or meaningful pain. And as you see here, about half of the veterans had reported having that level of pain. If you can see above each bar, a number of who fell into that score point. So you see under number 4, the red, where there was one person, et cetera. So all of the red indicate the people who were at 4 or above on the pain scale. And rather remarkably, this was not a hypothesis in the trial, but when the data was analyzed between the two groups, the drop in pain for the ART participants was substantial in self-reported pain reduction and a mixed bag in the control group. The mean changes were also striking, 17 points in the ART group and 0.7 in the control group. This was an unexpected finding, and we published this in the European Journal of Psychotraumatology. Kevin's an epidemiologist, and he loves to pool data. So I'm not telling you about the second study here. We just don't have enough time. But he pulled the data from the studies. And this slide compares the data between civilians and military people. And it also shows sexual trauma, which was among females. Here's a way to look at how each group started on their PCL score and where they were right after doing ART, and then a 3-month follow-up. You can see that the patterns were all similar, and you can see that the most notable outliers, that second cluster of 3, those are the military females. There were 9 of them, and they had the highest starting point with a mean PCL score of about 60. Remember, the cutoff is 44, so that's well above the cutoff to indicate PTSD. And they had a high prevalence of military sexual trauma, which is quite a big problem in the military. This was also published in Military Medicine. A closer look at the sexual trauma as the source of primary trauma. Remember, green is good, at least a 10-point drop in the PCL score. Civilians had a 22-point drop, and military females had an average of a 21-point drop. So it appears that ART is a very good treatment for sexual trauma. Because of the surprising results on pain, Kevin decided to look at neuropathic pain. In the group that he had, he looked at pain related to diabetes, chemotherapy, and pain that was of an idiopathic nature. He recruited 10 adults, so this is a pilot study, And he measured before, after, and 1 month follow-up. You can see the suggestion of the trends pre and post ART. On the scale on the left side, that reflects the level of pain. So you see clearly the level of pain is going down. The scale on the right side reports quality of life. So you can see clearly that that scale is going up. Finally, I'll just mention that lately Kevin has been very interested in doing EEG studies. And here you see a little case series with 9 veterans who have PTSD against 9 control subjects that do not have PTSD. So what they did is they took a nap before they had ART, and they had their EEG done, then they had ART, and then they had another nap and another EEG afterwards. The control group just had 1 EEG with a nap. And here were the results. In red, you see what the EEG, when they showed the level of discomfort that by virtue of the brain waves, in red, pre-ART. In green was the nap after ART, so clearly you see a trend going down, not down as low as the blue dots, which indicate the people who didn't have PTSD, but clearly in the good direction. So right now, I know he's gotten a much fancier monitor that he can put on someone's head that's less intrusive than all those wires that have to be put on. And so currently, I know that he's conducting another study using EEG. So this is, again, the list of articles that if you'd like to take a picture, or you can find easily on Google Scholar. And that concludes my talk.
To finish up today, we have a really, really short video. It's about 3 or 4 minutes, and it kind of illustrates a little bit of what we're talking about. And we'll be available a little bit later for questions and answers. Amy and I have a table set up down against this wall back here, and we're almost done.
Ready? 3, 2, 1, action.
125 decibels right there. We're gonna have to clean this up.
Where do you want me to stand? I just like walk up, introduce yourself maybe more times.
Okay.
Just like, cool.
And then when they look around, you guys are completely normal, like nothing happened.
Hey, good morning.
Hey, how are you?
Good, how are you?
Good.
Can I have a hot chocolate?
So you just want, do you want a double espresso or a single?
Double is fine.
Okay.
You got whole milk?
I do.
Let's do it.
Okay, do you want a medium, large?
No, medium.
Medium, and do you want that for here?
Yes, please.
All right. Let's get this going for you. Do you want that for here to go?
For here is fine.
Okay.
All right, get ready. 3, 2.
Okay.
Did you hear that?
Hear what?
That explosion.
No. Just making some coffee. What's the weather like outside today?
Freezing.
Is it? Yeah, I'm not a big fan of the cold. That's why I live here.
He's gonna shake it. Get ready for dog barks.
I don't know why I do it, but sometimes I just have to shake the beans too. There you go. Thank you very much.
What was that?
What was what? You guys enjoy the day?
Thank you.
Let's get out of here.
I don't know.
Hey guys, come on over here. We've got cameras right here, and we've got a camera right here, a camera back here, a camera right here, one right back here, one right up there. And if you don't mind, I'm gonna take you in the back here. Just go on through.
Thank you.
Oh, you okay? What happened there? I'm veering you onto the one coffee I know how to make with my 4 hours of training as a barista. So, did you notice at all that no one else was reacting to the noise?
Uh-huh.
How'd that kind of make you feel?
Alone?
I just wanted somebody else to be on the same wavelength as me, because I felt like I was the outcast and nothing happened. Nobody looked around, nobody looked at me, nothing.
How'd that make you feel?
Isolated?
What would you think if you had to deal with the same things you dealt with today, every day?
That would be debilitating. It would be scary to even leave my house because you don't know when or what to expect from day-to-day life.
That's what 24 million U.S. citizens deal with on a daily basis. It's not mostly veterans. Really? A lot of people go through a lot of difficulties with post-traumatic stress. Did you hear the dog bark? Did you hear the car wreck?
I did, yeah.
I was a Green Beret. I lost 5 friends in a 6-month period. You know, it's hard. It's just a memory or emotional attachment to something that you need to work through.
It's jarring. And not just my personal, but to hear the numbers and to hear your story a little bit and know that people are suffering in silence. It's always been the sort of thing where you don't really talk about it, and that's not right, you know, if we're gonna heal. You know?
Chris, come here, brother. Get another hug from you. Thanks, man.
Thank you.
Yeah, man. I really do.
Right on, man. Yeah, nice to meet you.
Nice to meet you as well.
Yeah.
Thank you for doing
Yeah,
this.
of course. Thank you.
So if you have any trauma symptoms at all, with or without a diagnosis, my compassion is with you and for you. You may never have been in combat and you may never go to combat, but in several ways you live combat on a daily basis. What I've heard in this conference Friday, Saturday, and again today, that many of you fight the fight and manage your symptoms as best you can, manage emergencies and crises as best you can, and a doctor, your physician, may never see this other side of you, may never see what your family members are going through, may never see at 2 a.m. when that overwhelming sense of anxiety or that dark depression comes, or these startle reflexes, or so many of the other things that we talked about today. I want to encourage you, if this is you, if you experience these things, to support your physical health, I would encourage you to consider seriously your mental health, your emotional health. I would encourage you to find someone who can do that. You can look for people who specialize in trauma treatment, anxiety treatment, depression, and so forth. We're going to send Linda also a link that will have a place where you can search for ART therapists on there. If there aren't any in your area, then this phone number is a phone number you can call and talk to them about maybe coming to your area and training therapists to help you. So I appreciate you very much, appreciate your patience today. Thank you so much.
Does anybody have any questions for Ann or Amy?
So you said that a possible symptom can be a loss of memory. If someone doesn't remember something, or if they remember it wrong, which you didn't mention, but can that be something that can be fixed by this, or will that stay the same but just not be so traumatic?
The latter.
Okay.
When somebody sits with me and I do an ART session, and Amy alluded to the eye movement, and we direct that with our hand when we're going through the session. What we do is we challenge that brain in the way that that memory is stored. It's stored together with both the memory of what actually happened and also all of the feelings that went with that. And then the triggers come out of those intrusive thoughts and memories from that. So we challenge that brain to separate those responses. And as we start working with somebody, we see that autonomic nervous system kick in. When I start working with somebody and they start remembering what happened, they don't have to say what happened. But as soon as they start remembering it, whatever their coping strategy is for their body, that brain sends those signals, and that happens. Increased heart rate, increased respiration, tightness in muscles and body. And as those things are coming, we immediately go to work on separating that from the memory. And it's very, very effective. I wanted to also add one thing. One of my clients has a difficulty with vertigo. And talking with the woman who designed this particular approach, what she suggested is, as we do the eye movements, that she should close her eyes and do them more slowly, and that we could proceed through the session as she needed, just timing it in a way that would be effective for her, that wouldn't be overwhelming. And we just took extra time. I scheduled extra time that day, and we just took all the time she needed. So I hope that's helpful.
My daughter is going through EMDR therapy right now with a therapist, and
wonderful.
And the therapist actually uses a hand stimulator instead of the eye movement. Is that just as effective, or what is your experience in that?
I'm not familiar with the research on the comparison between the two approaches. With EMDR, I'm not a trained or certified EMDR therapist. But I love the question, and for me, I would be just as intrigued, and I would want to know that difference. The one thing that we do know is that the reports that you've seen, if somebody had already had EMDR and was still struggling, if they go then and have ART sessions, what they're looking at is usually a reduction that's drastic in those symptoms, or an eradication, an elimination of those trauma symptoms. It's pretty phenomenal. Amy, you had something?
And I want to just add to what Ann said. We really prefer to use the eye movements, so closing the eyes, if that could work, would really be ideal, but not because of what research tells us necessarily, although research does show us that the smooth pursuit eye movements are correlated with relaxation. I got to get in the hot light. So the eye movements have been shown smooth pursuit, so if you're watching a tennis game, back and forth, they're correlated with a relaxation response in the brain. So we do prefer eye movements, but if it's determined that absolutely a person cannot do it with the eyes open, they cannot do it with the eyes closed, we can do other forms of bilateral stimulation. Like I think for the EMDR, you were talking about the wands that the person holds in both hands and a pulse beats from one hand to the other, or tapping from shoulder to shoulder, or have the person themselves tapping back and forth. So we would go to attempting bilateral stimulation without the eye movements. We can experiment and find some way that the person can tolerate and have that bilateral experience while we go through the protocol.
Thank you. Thank you, Amy.
Yeah?
Go ahead.
Okay. I had EMDR therapy many years ago, 6-7 years ago.
Yes.
I had surgery in 1991, and I was in a full body paralysis. Anesthesia didn't work, and I showed only one tear here every time,
Yes.
but they didn't see it. And I felt the cutting and the drilling, that kind of things.
Oh.
But I'm okay with that now. I had, yeah,
Yeah.
I had surgery after.
Yes.
It gives me okay feeling.
Yes, yes.
And I needed that second
It's very
and third
helpful.
surgery.
Yes,
And,
absolutely.
it didn't work only the months I visit the therapist, but
Yes.
even now it's still progressing.
It
Is
continues.
that a good word?
Yes.
Yeah?
Yes.
Okay.
Yes, very
So
good.
I'm much stronger even.
Yes, and I really love what you're saying, because once we gain some traction with something that really bothers us, hurts us, and keeps us down, once we get some forward momentum in that, that is so encouraging, and it gives us such confidence to just push, push, push to get better and better and better. And I love that you got relief. That's absolutely wonderful. It's beautiful. Thank you for saying that.
Hello.
Hello.
I'm not afraid to say it, but Ann is my counselor, and I have had ART, so if anybody has any questions from a personal experience of doing ART, I'd be happy to answer them. And I did it, and we're going to do more working on like the medical trauma of emergency rooms. I could probably ask you to raise your hand on who has medical trauma in an emergency room, and we'd probably get 100% response. So anyway, that's one of our goals eventually.
Yes.
So thanks for being here and for your information.
Thank you, Christine. Thank you so much. One last note, those of you that are here today, if you take a look at this list that we talked about earlier, if you feel comfortable in doing so, if you have experienced significant struggles, and I'm not talking about completely debilitating, but just some pretty serious struggles with any of these conditions, will you raise your hand? Anyone with any of these conditions? Those of you who are physicians, will you look around and see that this is the case with some of your patients? And if they are encouraged to and supported in getting mental health care, that would go a long way in addressing some of these issues. That would also very much stand to support what they're going through with PP. So once again, I thank you, and I'll send that directory link out to Linda and get that to you. Anyone else?
I think one of the big challenges as a physician, we always dump the mental health on the primary care docs. The primary care doc has to screen for depression, screen for all these other issues. And then when they go to a specialist, like if someone comes in to dermatology and they have, bad skin disease, I know they have psychic trauma from their skin disease, and they for the last 20 years they're walking around, embarrassed about it, and plus. But I'm so busy taking care of the skin disease that I don't have time to start exploring the psychological. And then if we do go there, and I say, okay, well, you should see a psychiatrist, well, they either can't afford a psychotherapist or a psychologist, or their insurance doesn't cover a psychiatrist. So what do you do if they need it and there's no access?
That's a great question. One of the things that I encourage people throughout our community, and I practice here in Central Florida, one of the things that I encourage is that you call around and talk to some therapists and talk to them about a sliding scale fee. Some people do pro bono work as well. A portion of their practice is dedicated to pro bono work, and that is that therapist giving back, and they will take X number of clients on their caseload for free. So I would definitely ask about pro bono work. I would also then come back and ask about sliding scale fee. My rates are probably right at 50% of what the going Central Florida rates are. I try to keep my rates low. I have low overhead because I'm provided a free office, which helps, but do ask. And those of you who don't have access immediately to mental health care, some of the things that we're talking about You may be able to access through video sessions as well. Those are available pretty readily now and growing fast. That's one of the fastest mental health care advances in our system.
Also, it's a good time for me to remember and to mention to you that the people who sponsored the table and flew me out here to join in at Art International are being sponsored by a philanthropic wealthy man, Chris Sullivan, who gained his wealth initially by being a co-owner of Outback Steakhouse, and since then he owns many chains of restaurants. There's one out here called Carrabba's. There's several others that he owns. So because he's so wealthy, he has a passion for treating PTSD, and originally for treating PTSD in veterans, but that's branched out to everybody. He has a couple of opportunities for people. So anybody who's a veteran and who's suffering from PTSD, he has in Holiday, Florida, a retreat for any veteran for free. He'll fly them there from anywhere in the country, and they'll spend a week. They'll get art, and they'll get yoga, and they'll get some other things. And also, if you call them, they have some other organizations that pay for therapy. There's one called Rebecca's Angels that's paying for a woman who's got trauma who's seeing me in Massachusetts. So if you call them, they might have some ideas of where you can find funding for therapy.
Oh, thanks. And I actually think we found a new condition, PTSD. There we go. Got a new, okay, so we got one more.
We got one more here from Aaron.
All right.
Aaron wants to make a comment.
Before I found a therapist, they sent me to the police, to the military doctors, and they refused to help me because I had paralysis. So maybe it's hard to find a good therapist who's willing to help in the hospital.
Yes, a very good point, thank you. And I would say if you hit a roadblock or a stumbling block, don't stop. Don't stop looking, because there are more of us out there. If you don't get a yes from one, call another. And if they can't see you or won't see you, to me the magic question is, who do you refer to in my situation? Who in practice are you referring clients to? And I would just keep calling, keep doing that research until you find somebody. And again, if you look for somebody who sees people with chronic medical conditions, you will most likely find someone who's doing this kind of work.
Great. So it is like 10:50-ish. The remainder of the conference would be, I think, just kind of open question and answer. If you have any stories to share or questions about your own medical condition that might be applicable to everyone else. But I feel like we should take a break for like 10 minutes, and then whoever comes back, and we'll hang out for 10, 15 minutes, but maybe we'll end a little early. So thank you guys. Hi, everybody. I think that it's time to wrap up the PPA 2019 conference. I just wanted to thank all our members for coming and being so supportive of each other and of us, and all our speakers for giving wonderful guidance and wonderful information. And we'll try to do something next year. If not next year, definitely the year after, but probably next year. The room will be open until 1. Then doors have to shut, but feel free to hang out, mingle, and I think in maybe like 5 or 10 minutes, I can give a little overview of, for first-time people, anyone who wants to hear about, the basics of hypo, I can give a little thing at one of the tables here. All right, bye everybody. Hey, Eric, are you around here?
so I'm a little bit
Sweaty?
Yeah.
That's fine. I
Right
got it.
for the next slide and left for the prior slide.
Perfect. Thank you. Hey, guys. If you have any interest in listening to like the basics of PP 101, you come to the front here. And maybe I'm not going to use the mic, so. All right. So I like to identify hypokalemic periodic paralysis by management of it by the triggers. If you prevent the triggers, that's your. I mean, it's half the game, but it's not your best bet, but it's a very good bet. And that has to do with exercise habits and diet, and we'll get into those. Then you have to deal with acute attacks, right? You're paralyzed. What do? And you have to understand how to manage these at home, and you have to understand how to manage them in the hospital. And at home, when to go to the hospital. That's like even another thing. And then preventing attacks, you got to get on the right medication regimen. With various diuretics and various formulations of potassium. So a lot of people have had some success, doing a diary. And with a diary, what you're doing is just taking 2 weeks, a month, maybe 1 week, it can get kind of cumbersome. And just keeping track of every medication you put in your body, every food that you put in your body, every exertion that you do, and then and then document when you get an attack and what was paralyzed and how badly, and you can make your own little severity scale. How long did it take for you to regain movement? How did you medicate? Some attacks, like I did this with a diary, and my neurologist, before I was in medical school, saw that I had one big attack, and then I had 3 days after that these smaller attacks, and I thought I just had 4 separate attacks, but it was really just one attack that I never quite got out of. I think that makes more sense. So, so what did I learn? That, maybe in retrospect, I probably didn't fully treat that attack. So maybe I took 40 of potassium or 60 of potassium, and I probably needed 80 or 100 of potassium. So these little things that you learn about yourself, and it's knowledge that takes, we learn how to deal with this over decades. And over like a couple of months, you start learning certain patterns, and now you think you have the patterns, and you're like, all right, I'm all good. And then like your body changes because you get older. Or like, for me now, like I've been working out a lot recently, and I have more muscle mass, and now I need more potassium, the game changes, and, foods that I didn't get paralyzed before, now I get paralyzed with. So you got to pay attention to, day to day. I tell my medical students, you have guidelines, you have a recipe to make a soup, right? And you put 2 onions and some carrots, and you can't just blindly just follow the recipes. You have to taste the soup as it's cooking. And sometimes it's less carrots and more onions and more broth or less broth, and you make adjustments. So that's like really important. You got to taste the soup every day. Okay, so the triggers diary, so activity. If you have a pretty consistent routine, that's really helpful. When you have changes in routine, like coming to Orlando and waking up at god-awful hours and stressing out, that's when you're going to get attacks, you know? So if you keep your life on a kind of even keel every day, same exercise, same routines, it's a little boring, but it does keep you stable. And then you can experiment going a little bit out of the box. And then, you know, and of course we test our limits. How much out of the box can we go? Be it food, be it exercise, be it staying up late, being, you know, alcohol, whatever it is you're going to do. And then you know, you get a slap on the wrist when your body says, you know, you messed up, and then you pull it back. The other triggers that you want to, other than activity, you want to worry about like carbohydrates, salt, alcohol, MSG specifically, so different food triggers. And then medications, when you take medications, sometimes they sit well with you and sometimes they don't. And I always tell people with periodic paralysis, any new medication, doesn't matter if it's an antibiotic, if it's a pain pill, if it's whatever you're going to, blood pressure medicine, it could, you know, psychiatric, like depressive medicine, like it could be a trigger, it may not be a trigger, you can't really tell. Unless, of course, the intrinsic property of the medication is to pee out potassium or conserve potassium, of course, then you might predict, you know, an effect. Certain infections, like some people, when they get the flu or they get a sore throat, they say, you know what, I don't get, my attacks stop when I'm sick. And other people say, boy, like when I get sick, I am in double trouble. I get more severe attacks. That actually happens with me. I fear the flu like the plague. Well, maybe not. I think I'd fear the plague more than the flu, but if you get diarrhea, by its nature, diarrhea is a potassium wasting situation. When I was in this hotel a few years ago, I ran myself ragged. I probably ate some of the wrong things, but I also had shrimp in a land remembered. And, you know, so I got my potassium went down. I had to call the ambulance. I went to the ER. I told the EMS what to do. And then I didn't have the energy to talk anymore. Like my breath just wasn't, I could breathe, but I couldn't really talk well. So I had to listen to the EMS tell the ER doctor like everything I downloaded. Thank God they said it correctly, because I couldn't have I couldn't have corrected them at that point. But anyway, potassium was really low. I thought my body was freaking out. I'm sitting there, I couldn't move, and I just had this like random diarrhea, and I couldn't move, and I was just a mess all over the place. It was so embarrassing, and I just assumed that it was low potassium, and my body freaked out. Finally, my potassium got better. They gave IV, oral, and it was like 7:30, and I'm like, oh, time to run the conference. So I pulled out the IVs. I signed out AMA to the conference. Maybe that's a bad idea, but there was like 200 people, you know, like. But on my way out of the hospital, I had like a bloody diarrhea again, and I'm like, okay, this was an infection, this wasn't, and that's why I probably got so profoundly paralyzed. I was tired, I ate the wrong triggers, and I had this infectious event causing diarrhea, and all three, there's only so much your body can take. Anyway, lack of sleep, another issue. Weather, barometric pressure, or cold. You know, when you know that the thunderstorm's coming, and some people feel it in their joints, other people are just like, you know what, I'm feeling more susceptible to an attack. In that situation, maybe that's a time to K up, you know, and that would be like preventing a trigger. So like if you know you're going to do exercise, take potassium. If you know that like the feeling's in the air, that something's funny, maybe just take extra potassium. And maybe don't have that slice of pizza that you might have treated yourself to. Some people with menstrual cycles, it's their worst, better. Do you guys notice anything with the menses? Yes, no? It muscle pain, but I don't know. Anyway, whatever. But you pay attention with the diary. I know when I get my period. No, I'm just kidding. Oh, here's the thing. Not all triggers trigger every time. So I would go to this Japanese restaurant, and I'd have the hibachi steak and broccoli and a bowl of rice. And, like, I'd have that. I'd go home, and I'd be fine. And then, like, I'd have it again one day, and I'd be paralyzed. And then I'd have it again, and I'd be fine. And I'd be like, well, it's not happening to me every time. So clearly it's not the hibachi meal with the rice. And after so many times, you realize that, you know what, first of all, yes, it is the rice, and it's probably the incredibly salty meal that they put in that. And the rice some days will paralyze me and some days won't. But you know what, better just not to eat the rice. So now I go there, I ask for no salt. I ask for, they put the rice, I don't eat it, and I enjoy my meal. So if I don't eat for a long time, so I'm giving part of anecdotal experience, but I think it matches other people's. I'll also, be susceptible to paralysis, and I think that if you don't eat for a long time, first you're going to get paralyzed from that, but then you end up gorging on things, and you've had too much carbohydrate or insulin spike, and that's going to cause paralysis. That little slices of pizza, man, that's the best pizza place in my town, and I can't have it. But like pizza, there's certain things, there's certain things like, let's say a hamburger bun, that like, it's bad, but it's not like death, And there's certain things that are just like periodic paralysis, death, for me, it's like macaroni and cheese, Kraft macaroni and cheese. Between the salt content and the pasta, it puts me down like profoundly down. Gatorade, I don't know. I used to drink a bottle of Gatorade. I swear, I drank a bottle of Gatorade a day for like 10 years. Until one day I just started realizing every time I took a sip, I felt so horrible. So I avoid that. So like pizza, pasta, mac and cheese, too much bread, potatoes. Are there better complex carbohydrates? I, eat soba noodles. Why do I have so much Japanese food in my diet? I do karate, so that's the cultural influence. But the buckwheat, for some reason, I can handle that, whereas I couldn't handle just straight up pasta from Italy. And then quantity plays a role. If you're gonna break down and do it, you have a bite of pasta. You don't have the whole bowl of pasta, so you got the flavor of, okay, yeah, I remember the taste. It's nice, okay, and then. And that double chocolate cake after the giant steak, after the shrimp, no, just don't have that, or just have a bite. So what can you eat? Nothing. No, I'm just kidding. I find like protein is good. Best to find alternatives you can eat rather than just identify everything that you can't. So they always talk about that in nutrition. Rather than say you can't have cake, you can't have pizza. Well, no, you can have chicken. You can have a hamburger without bread. And then it's unlikely that foods high in potassium will make you not need treatment. So people are like, oh, well, just eat a banana, right? Two things with bananas. One, banana and potato, they have a lot of potassium, but they also have a lot of carbohydrates. So like my sister, when she eats a banana, she gets paralyzed. When I eat a banana, it's neutral, I think. I probably get paralyzed and I'm ignoring it, who knows. But the thing is, if you eat like a lot of bananas, I think in the next slides, one medium-sized banana has, so much potassium, not that much, 12 milliequivalents. And not of all of that will get absorbed. So of the 12, maybe it has like 4 that's really going to get in your body. And it has 28 grams of carbohydrates. So you'd need 6 bananas to get yourself, quote, out of an attack. That's going to give you diarrhea and put you in an attack. It's going to make you paralyzed from all the carbohydrates. And yeah, it's 1.5 pounds worth of bananas. I mean, that's a lot. Things that are, some people found helpful, some people don't. Calcium, magnesium, but more importantly, potassium chloride. I mean, that's the core of our therapy. I can't really comment in an evidence-based way on the benefit or lack of benefit of calcium, magnesium, phosphorus. Some people, if you find that you're not great with just potassium and acetazolamide or Keveyis or Inspra or Aldactone, all those diuretics, then you can start exploring, well, what if I take calcium? And you'll see better or worse. What if I take magnesium? Better or worse. What if I have the Diet Coke with the phosphorus? Better or worse. And blood tests also help. There is this stuff called new salt or no salt in the spices section of the supermarket. A 3-ounce jar has 19 doses of 60 milliequivalents. So if you have to do the Harrison Ford, what was that movie where he was his own doctor and Fugitive, The Fugitive? So, and your doctors aren't giving you prescriptions, but you feel like you need to self-treat. I mean, I think this is like one option. I don't advocate it per se. I just get a prescription, but like if you have to. Then there's potassium. There's a lot of dosage forms of potassium. I like to put if it's powder, potassium chloride powder, you can dissolve it in apple juice, that's sugary. You can dissolve it in orange juice, that's acidic. You can dissolve it in bubbly water, that'll make you feel like burping while you're paralyzed, and so now you're going to feel like throwing up while you're paralyzed. or just put it in water and just learn to love that taste. And initially it tastes so yucky, but then you start to feel like it is just the lifeblood of, you suck it down and it makes you feel good. They have solutions that are pre-made. I've been to the hospital and they have these little packets and you peel it open and it's pre-made stuff. That works just as well. They have the fizzy tablets. I'm not a fan of the fizzy because, again, it's bubbly, and for me, the bubbles disagree with me, but other people, they swear by the fizzy, so it's really personal experimentation. And I've, throughout the conferences, absolutely, have I traded potassium with my neighbor? Yeah, I mean, I can't advocate for you to do that, but that's how you find out. All of these packets now are like $21 for one packet. Like they did some FDA finagling where like they did a clinical study and got all the generics off the market and then jacked up the price. So the potassium chloride is very expensive now. Great business that the PPA maybe should get into. Then if you use a sustained release tablet, so the K-Dur, the horse pill of 20 milligrams of potassium, you drink it and it just sits in one little spot on your stomach wall as it dissolves over the next like 2 hours, and it eats away through your stomach wall. So if you do it once, that's fine, but you do that day after day, you're going to get really, I would predict that you get stomach irritation. So there's a role. Some people, like, Shelley swears by those pills and not the immediate release. I swear by the immediately release and not the pills. A trial and error. I used to do the pills. I remember I got badly paralyzed. I couldn't really move. I took the pills, it was like an hour, and then I burped, and I just felt all those granules in my throat, and had it gone a little higher, I would have choked to death probably. And it would have been bad. I remember my dad calling the Bud Rowland, who was like a big neurology expert at the time, and no one knew what to do. So I lucked out. But that experience, I just remember, like, when you take the potassium, it doesn't act immediately if it's in a pill. But if you take the liquid, you get a big spike, and that reverses all those ion channel electricity things. So if you take a sip here and then wait, and a sip there and then wait, that's not going to do it. You need like the 40 or the 60 or the 100, like all at once. And then you wait, and then you see in 15 minutes, a half hour, an hour, things aren't going in the right direction. If you definitely feel like you're getting worse, take more. If you feel like things are going in the right direction, the question is it going in the right direction fast enough? That's kind of when you take more, or just sit and wait. And then intravenous is dicey. You can only get 10, maximum 20 milliequivalents in a vein. It burns like hell as it goes through. And if you need 100 in your stomach to immediately get, if you only take 20 by the IV over a half hour, you're not going to get anywhere quickly. Now, if you completely can't speak, you can't breathe, you can't swallow safely, yeah, you're going to do the IV drips and drabs until such time as you can kind of sit up, and then you can suck it down and get the medicine in a fast way. When I was in the hospital here, they were talking about putting a nasogastric tube down. I feel like if you feel like you're going down, but you still can like have a cough reflex, that's the time to put in a nasogastric tube. So the tube is in. But if you have that jelly to lubricate the tube and you can't cough, so now the jelly was going to be going down your lungs and you can't, so that's going to cause an irritant pneumonitis. You're going to get into a big problem. So at that point, maybe IV. But I thought it was very clever that if they had the NG tube while I'm up, and then I couldn't, and they put the salt in just through the NG tube, you'd get a whole bunch of potassium in the stomach without having to mess with IV, and you just keep the person up a little bit so they don't throw up, and maybe that would work. So an untested idea, but it's, if you're going to do intravenous, don't put the potassium in D5W. And of course, this is all for hypokalemic periodic paralysis, right? Because that has dextrose 5% is sugar, so it's glucose 5%, and that will spike insulin and drive people into an attack. So you go to the hospital for low potassium, they put the IV, they drip the D5W with normal saline, and now they're giving you salt and sugar and driving your potassium lower. So maybe you were better off staying home that day. But, if you do give the potassium in mannitol, so you put 20 milliequivalents in 100 cc's of mannitol. 100 cc's is not very much. So if you give a lot of mannitol, it messes up with brain swelling things. But if you give a little bit, it's inert, and then you can get the potassium in. So potassium is K+, and then there's a lot of counter ions, chloride minus, bicarbonate minus, gluconate minus, citrate minus. There's maybe more minuses on the gluconates and the citrates, but it doesn't quite matter which one you use. The K+ is the thing that's important, but of course some people are going to respond to this versus that. The oral route is preferred. Prescription, when you get a prescription for the maximum anticipated daily dose. So like, I wrote myself for 3 packets twice daily. So that's like 6 packets a day. That's more than I'll ever need. However, as I'm exercising every day, I actually am using 3 packets before exercise and then maybe 2 or 3 packets at bedtime so that when I wake up the next day after the exercise today, I'm not paralyzed. So I really am starting to take, 6 packets a day. So that now I don't have that much potassium in reserve if I need extra for something, if I'm doing, so like that means I really need to have like 9 packets a day written. Now insurance is not going to pay for that unless you get like a prior authorization, because each packet's $21 now, right? Although if you buy 100, they say, okay, fine, $7 a packet. So like depending on how many bulk you get, they'll bring down the price. But so that's one barrier, is insurance, but you have to advocate. You have to tell your doctor, look, the maximum amount I need is this. And not only that, but you want to have extra in your bag, extra in your suitcase, extra in the kitchen, extra in your car, so that when you extra in your pocket, so that when you leave the house and you took potassium from your pocket, but you forgot to refill your pocket, well, you better have a spare here and there and there. And yeah, it's going to expire at some point, but you just have it lying around everywhere. But that's going to increase your prescription requirement, because that's more than just what you take per day. So that's like kind of important. And then you have to overcome, aside from the insurance issue, the doctor's going to be like, 6 packets of potassium, I'm going to put you to cardiac arrest. And so we've had that issue, and you have to, that's just a negotiation thing. And, shame on me. I wanted to write a paper about potassium metabolism and the safety of taking how much potassium, and certainly in this disease relative to a regular person. And it's on the things to do list. So management in acute and attack, I kind of sort of pulled this 0.5 to 1 milliequivalent from my butt when I wrote the paper. It was the best I could think about in terms of I was about 60, 70 kilogram, and 60 worked for me, and that's what I heard a lot of folks doing. But certainly, people double down on this amount. People half up on this amount. It depends. I do like, again, we said taking a bunch all at once rather than little tidbits. I think doing blood monitor after 100 milliequivalents, maybe that's too conservative. Maybe it should be after 200 milliequivalents. But there's a certain point where if you have hypo and you take potassium, you should come out of the attack. And if you're not coming out of the attack and you're still taking more potassium and more potassium, at some point you do have to maybe understand where you are. Do you overshoot? Is there something funny with the channels that now you flip to hyper and now the hyper is causing the attack? Because it's so strange how this disease works. And I used to kind of view the disease as, I looked at myself and I said, well, that was what the disease was, and everyone else is a variant. Now I look at the disease as there's just a lot of variants. And I remember in the beginning conferences, people would come and, some of the doctors would be like, that person doesn't have, that person doesn't have, this person has, that person has. And now, like, most of the same people are here, and it's like, yeah, we all have it. That kind of thinking has evolved. And so the dosing of how you do potassium also evolves. I do tend to like the aqueous form, though. So we said 10 milliequivalents every 20 to 60 minutes. Try not to overshoot. The people who overshoot the most are the ones with thyrotoxic periodic paralysis. They talk about the fact that when you get an attack, okay, your total body potassium is like some amount, all right? And your blood potassium is some amount. When you get an attack, the potassium, nothing is peed out and nothing is eaten. But it just shifts from the blood to the muscle. And now if you measure the blood, it looks like you have low potassium in the blood. But if you could measure the muscle, you'd have high potassium in the muscle, okay? But you can't measure the muscle. And then when the attack ends, all of that extra potassium from the muscle goes back to the blood, and then everything's normal again. So if you start pumping the body with a ton of potassium, you could overshoot. Now, the reality is that for hypos, when you pump the body with potassium, as it corrects, the kidneys is peeing it out. And so the kidney is what's peeing out the extra. That's my understanding of it. I guess I haven't measured the urine potassium over the 2 hours following, oral administration of potassium after the attack goes away. I mean, that would prove it, because it has to be somewhere. It's either in the blood, in the muscle, or in the pee, right? If you've eaten extra. But anyway, the people with thyrotoxic, their thyroid's high, they have the carbohydrate meal, they wake up the next day, they're paralyzed. The potassium is all in their muscle. Their potassium is like 1.8 in their blood. You give them 300 milliequivalents of potassium, their blood gets to normal, and then that relaxes the problem and everything resets back, and now they spike, and their kidney for some reason doesn't filter it out as much. And maybe it's because thyroid hormone, you make me make up an explanation, limits the kidney's ability to filter out the potassium as efficiently. Who knows? But those are the folks that get into real trouble. I would never do more than 40 or 80 milliequivalents of IV potassium, and you're going to have to use a central vein if it's more than 10, meaning that you can put an IV in your arm and put 10 milliequivalents at a time, but otherwise they have to go in the neck if they have to put more concentrated. And then I like to take medicine, and this is kind of personal for me, and people can mention to each other, 15 to 30 minutes prior to exercise, I'll do like 60 milliequivalents. And that usually saves me for like 2-3 hours of pretty rigorous exercise. I mentioned before bed, after exercise or a carbohydrate intake that evening, you can either take the horse pill, the slow release, or take the liquid. Either way, it protects you for the morning. Let's say I exercise in the morning, I take 60, and then I have to exercise again, 5 hours later, I might take another 40. But if I have to exercise in the morning and in the evening, then I might take 60 in the morning and 60 in the evening. You have to decide what's good for you. What is the potassium effect on blood levels? So, let's say 60 milliequivalents of potassium will increase your potassium by 1.5. So if you think that you're at like 3 and you want to be at 4, you should take 40 of potassium. Now the reality is that I find that you need a little bit more than that with hypos. If you think about 160 milliequivalents, it would increase your potassium by 3.5 change in point. So basically each 20 milliequivalent will get you up by 0.5. That's what they have that's what the emergency room doc will be thinking when they dose potassium. And that's kind of sort of true, except many times we need sometimes 1.5 that amount or twice that amount. So again, the medical, it's time to go? All right, what time is it? Okay, we got till 1, so. All right, so overdosing of potassium, it's a real thing with intravenous. It's less likely with oral. You'll get diarrhea before you'll overdose. You may feel tingling in your hands and face before you overdose. So that's an indication to stop taking. It also depends on the potassium deficit in your body. The fear is that if you get high potassium, you get an arrhythmia, and then your heart stops suddenly. I mean, that's what the doctors are all afraid of when they give you. There's a bunch of brands, but you have Chlorcon, you have Efferk, those are the two main ones. Chronic therapy and periodic paralysis, it's unclear which one to try first. I will just say that spironolactone blocks testosterone, and so if men take spironolactone, they get something called gynecomastia, which is larger, breast tissue. So better to avoid that in men if possible. And luckily, there's a medicine called eplerenone or Inspra, which works to save potassium in the urine, but does not have the breast thing. So that's good for guys. There are carbonic anhydrase inhibitors, so acetazolamide and the dichlorphenamide. It used to be Daronide, now it's Keveyis there. Then there's potassium-sparing diuretics, so those save potassium, the Inspra, aldactone, triamterene, and amiloride. Triamterene often comes with a diazide, which has hydrochlorothiazide, so it comes in a combination of a potassium sparing and a potassium wasting. So don't take, if it has HCTZ in the name, don't take it if you're hypo, because you'll be peeing out potassium. That's great for hypers, but it's bad for hypos. And Dr. Lewis mentioned that yesterday. And then these experimental drugs, which are not really important now. Chronic therapy. In general, you don't take, if you have an acute attack, you take potassium. If you have an acute attack, you don't say, okay, I'm going to swallow my Diamox and that's going to make my attack go away. Now, I've heard one or two folks who do that and it works for them. God bless you. Okay, but in general, that's not a thing. The optimal dose requires trial and error. So how much Diamox can you take? They say you can take up to like 1 gram twice a day. Most people will get kidney stones and honestly brain fog and paresthesias, like tingling from that. I find it gives me kidney stones, so like I take 67.5 milligrams every 3 days. So that's like a small dose. Other people take 250 twice a day. That's kind of the average. Some people take less, 125. Any combination of that thing you have to do by trial and error. Some people may worsen when they take acetazolamide, so you have to be prepared if you're going to start on a new adventure with a diuretic. Have people around you, limit the commitments you have for that week, and be prepared with potassium on hand. And if one fails, try another. So if acetazolamide didn't work but didn't make you feel bad, maybe try dichlorphenamide, or vice versa. If acetazolamide made you feel horrible, chances are another one in the same family will make you feel horrible, so I'd probably try something of a different family. But the main guys that we mess with are acetazolamide, dichlorphenamide, or spironolactone and Clarinone. And you can take acetazolamide and a Clarinone, and that's okay. So side effects of the carbonic anhydrase inhibitors are tingling, confusion, kidney stones, worsening of paralysis, and if you have chronic obstructive pulmonary disease and you're a smoker, it can cause acidosis, and that can be a problem because you hold on to CO2 because of your lung problem, and you're peeing out the bicarb, which is the base. So you're making your blood acid from a respiratory point of view and from a metabolic point of view, and so that you double down, so that's bad. If you have high-dose aspirin, you also get acidosis, and if you take steroids, you can get hypokalemia with that. So. Acetazolamide wastes potassium. So if you're hypo and you take acetazolamide, you're going to have to take potassium on some regular basis. Spironolactone, you can go up to 200 milligrams a day. So like when I give it to women for acne, I give 100 in the morning and 100 at night. Side effects can rarely will be the breast tenderness and enlargement in men. And you can get, the fear is high potassium. Usually happens if you take like another drug that also holds on to potassium. So if you take like an ACE inhibitor for your blood pressure, that holds on to potassium. And you take aldactone, then you're going to get hyperkalemia potentially. Although it's not a bad idea maybe for people struggling to keep their potassium high, then that's actually an interesting strategy. If you use spironolactone and triamterene, there were reported 2 deaths. So if you do 2 potassium-sparing diuretics at the same time, that might not be the smartest idea. And just be careful about extra potassium, but that's if you don't have hypo. When you have hypo, then it's actually not so bad. Inspira or Clarinone is well tolerated. You can go up to 50 milligrams a day. Dr. Weber says he goes up to even 100 a day. It doesn't lower the blood pressure, but it does hold on to potassium more. So, that's cool. And this other one I'm not going to go through, but you can do combination therapy. And if you're on a chronic diuretic, you have to monitor other electrolytes. You'll pee out magnesium, you'll pee out calcium, you'll pee out sodium, chloride, bicarb, phosphorus. So you have to periodically measure these. Once every 3 months wouldn't be wrong, and that may be contributing to some people's attacks in theory. Safe physical environment at the bedside. You want to have potassium. You want to have water in a plastic bottle. Some people pre-make the potassium before they go to bed so they don't have to mix it. Have a telephone nearby. Avoid direct exposure to an air conditioner. So I fell asleep in college and the cold air was blowing on me. I woke up paralyzed because I was shivering at night. No. Potassium is potassium, and so that'll actually, it doesn't expire either. It's an element. It can't break down. It may taste like garbage because like the sweeteners break down over time, but in a pinch, if it's from 2010 and it's 2019, you can take it. It's potassium. It'll get absorbed. And then never be caught without potassium. That's what I was saying. Keep it at work. Keep it in your bag, in your jacket, on your person, and everywhere. Avoid slippery rugs or other obstacles. So if you know that you're the kind of person who's walking around their house, getting the potassium, and there's the rug there, and it's just don't have the rug there, and then, you can do that. Have handrails in the bathtub, handrails anywhere in the house, quite frankly, if you're or by your bed anyway, so that you can get up and navigate. And have a buddy system. If you live alone, make sure someone's calling in to check on you periodically. When I was in college, I was just learning about this, and I was in a single room, and I got paralyzed at 4 a.m. I woke up paralyzed, and I just had to wait there until the girl next door, I knew she was an early riser at 6 a.m. I finally heard her stirring, and I'm like, Maria, and she knocked on the door and, called the people and got them to break into my room and save me. But, it's much better after that I had my friend come and check on me every morning to make sure. Pregnancy, a Plerinone is category B. Amiloride is category B, and carbonic anhydrase inhibitor, specifically acetazolamide, is probably safe. Spironolactone will cause birth defects, and I don't know about triamterene so much. Muscle pain, it's not well studied. We didn't really address it at this conference, but it's totally a thing. I think keeping well hydrated is going to help a little bit with that. Maybe not like a non-steroidal like Advil, and you have to ask what works for people. Perioperatively, avoid epinephrine, avoid cold. You have to be NPO, nothing by mouth, for 8 to 12 hours before surgery. But someone, Bill Harr was mentioning, be the first case of the day and tell them that you can't be put off until 3 p.m. and just kept starving with IV glucose, because that'll harm you. And make sure the patient is checked frequently when they're off the respirator. Have someone at your bedside to check on you. And be aware of inadequate anesthesia. That's a major fear. But if you can't speak because you got paralyzed and they think you're out and they start cutting, that would suck.
With the meal orally before surgery, in Australia they've kind of changed that a bit. They've found that it's more beneficial to have something. So before my surgeries, they make me take 2 fast-acting.
Oh, good. Okay, even better. The hospital policy is different. You're not going to argue with that. Eye doctor and the dentist, epinephrine is a trigger, so use plain lidocaine. The beta agonist eye drops that they use to dilate the eyes is a trigger. That's like epinephrine. And so I've had success in one patient where I told them to use lacrimal duct plugs, meaning that the tears start up here and they drain. There's a little hole by your nose and it drains, and then it goes, so when you cry and you sniffle, it's because the tears are draining into your nose. So they can put little plugs in those things, and the tears drip out of your eye. And so the medicine would then drip out of your eye and not into your body. So that's an interesting thing. Thyrotoxic periodic paralysis, propranolol helps. It's in Asian males. Acetazolamide might worsen it. And then hyper, I don't know. I think we're going to run out of time. I don't have a ton of pearls for hyper. Here I was just kind of defining all of these conditions. But triggers for hyper is cold, rest after exercise, fasting, or having a low blood sugar. And, if you have an attack with hyper, sugary drink, insulin with glucose, or just glucose, But if you're going to give insulin, you better give glucose, because otherwise you'll drop the glucose, you'll get hypoglycemic, have a seizure. Albuterol inhalers, some people poo-poo it, other people say it helps. And then to stabilize the heart muscle rhythm, you give calcium gluconate. And in terms of chronic therapies for hyper, these are the potassium-wasting diuretics. Hydrochlorothiazide is classic. Acetazolamide helps as well. Keveyis helps as well. And sometimes Lasix works. And then, anything that is bad for a dialysis patient, you probably can follow that same diet as a hyper and, lessen your attacks. And then Anderson-to-Will syndrome is periodic paralysis, either hyper or hypo, with long QT syndrome and some skeletal abnormalities. And, basically you have palpitations and some very atypical attacks sometimes with the muscle twitching. And I don't even know where to put the muscle twitching and what box to put it in. Is it hypo with muscle twitching? Is that ATS? It's some form of periodic paralysis, and I tend to be more open about it than closed. And the main triggers are going to be the same thing as for whatever periodic paralysis you have. So if you have ATS and potassium makes you better, then sugar is going to be bad for you. And if you have ATS and potassium makes you worse, then sugar will be good for you. But maybe cold would be bad for you. And cardiac monitoring is important. You have to, some people have an AICD, a defibrillator implanted. There's a whole bunch of drugs that cause the QT interval, which is on the EKG, to lengthen. And if the QT is long, then your heart rhythm goes bad and stops. So you have to avoid drugs that trigger that. And then paramyoconjunct. PMC is muscle stiffness that worsens with exercise and with cold, and I'm sure some folks get that. But yeah, that's mainly the lowdown, the basics. So hopefully that was helpful. Okay. Yeah, managing asthma. If you have diabetes and you have asthma and hypo, it's tricky. But the lungs come first. If you can't breathe, you have to take the albuterol. Then maybe also.
That one is interrupting.
If you can't breathe, you have to take the albuterol, but then maybe just take potassium at the same time.
I'm wondering for my daughter who has symptoms, she gets albuterol. Is that the best, or should you?
Yeah, albuterol. There's a lot of different asthma medicines, but albuterol is like for an acute event. And then they have the steroid inhalers, which are also a trigger for hypo. And then they have the steroid inhaler and a long-acting beta agonist, which is like a long-acting kind of albuterol. Those are all triggers. Okay. If the asthma is significant, there are there's a drug called Xolair and there's a drug called Fasenra, and they're more like injectable antibodies against interleukin-5 or anti-IgE, and those things work against asthma, but don't have any axis on steroid or epinephrine or albuterol. So those might be an interesting, and Singulair. There's things that you can attack the asthma with that's not triggers. Okay. But they're expensive, but they're worth looking into. Yeah.
We also have EpiPens for everyone in our house, and I don't know, I wouldn't know what to tell them if we gave Epi.
Oh, okay. Well, so if you have an EpiPen because you're worried about the kid having an allergy and they have hypo, again, if the throat is closing and their blood pressure is low because they got a bee sting or ate a peanut that they you have to give the EpiPen, and they're probably gonna get paralyzed. But what can you do?
So you would just expect to give IV potassium to tell them, because we're an hour from the hospital. So.
Yeah. So I think that that's a real tricky thing. But I think that once you give epinephrine and hope that the paralysis doesn't happen really fast, but I mean, if it does, you got to do 911 and hope that they can get an IV, and it's just a little complicated, but hopefully you can like give the EpiPen and then give the potassium before things get too crazy.
Yeah, okay. Thank you.
Yeah. Question?
So I've got hypo. Not sure if it's related to that or whether it's just the, your sympathetic nervous system. Overheating head, especially at night.
Overheating?
Head.
Your head overheats?
Yeah, I have to sleep on an ice pack every night.
So is it like flushing, or is it just like...
Just really hot.
That is a bizarre thing. I've never heard about that.
Yeah, it's not so much night sweats, it's just, so the bottom part of my body can be under blankets. Occasionally my feet get hot and I just stick them out. That doesn't bother me. But the head, I've got to sleep on an ice pack and change it 2-3 times a night.
I've never heard about that, so I'm not sure how to explain that.
Yep.
I would be interested to know if you're managing your disease better, does that situation go away? If you take potassium, does that go away, or is that just some unrelated event?
Yeah, my doctor just, he's not sure. He just thinks it might be some sort of central nervous system issue. But over the last 6 years, it has come and gone a little bit.
Okay.
But yeah, I can't work out why though.
I had one question that somebody asked, is changing vision from 20/20 to worse something that comes with periodic paralysis? And I'm not aware of visual acuity problems on a chronic basis with periodic paralysis. I suppose if someone got blurry vision while they're in an attack, I wouldn't disbelieve it, although I haven't even heard about that. People don't talk about that as symptoms per se. More questions? If you have any more questions, PPA Ask the Experts. You put in your question with background information. The more, the better for me. I'll read it. I'll either answer it myself or I'll send it to like Steve Cannon or one of the other experts, and we'll get you an answer. So, anyway, thanks for listening. Good luck, guys.